script for this?
That's the script. Oh, the open. You can just say hearing come to order and then.
Okay. We'll call the hearing to order. The state of uncertainty, the implementation of the Patient Protection and Affordable Care Act's exchanges and Medicaid expansion. This hearing is under the jurisdiction of the Energy and Commerce Committee. I do want to observe as we start, the chairman of the subcommittee, Mr. Pitts, is ill today, and we all, of course, wish and pray his speedy recovery, and I understand that that is well underway, and we'll look forward to his return here to join us in the Congress next week. In the meantime, it's been 1,000 days since President Obama signed the Affordable Care Act into law. The Obama administration has not provided critical information to members of Congress, to the states, or to the health plans that they need to begin implementing the health laws exchanges. We know Medicaid expansion is going to happen, but we don't know what it's going to look like. We know insurance market reforms are occurring, but we're not sure about what is going to be expected of the plans themselves. The President's law intends that the exchanges will be ready to begin enrollment by October 1st of next year. In less than 10 months, the administration asserts that they will have a fully functioning, technologically advanced system by which Americans will be able to enroll in an exchange. The administration has yet to explain how it will share information between the 3 different federal agencies that are involved in determining eligibility for the exchange: Treasury, DHS, and Health and Human Services. And further, the administration has yet to explain how it will distribute the income subsidies, the cash, to the beneficiaries to allow them to purchase coverage in the exchange, or how a state will be able to afford the administrative costs to deal with eligibility changes. While the administration has the ability to push back the dates of implementation for federal positions, the states and the plans that are required to meet statutory standards do not have that flexibility. It was not until last week that the administration released the proposed rules regarding the state health insurance exchanges and the essential health benefits. However, the latest proposed rules and the other 13,000 pages of rules that the administration has released on the Affordable Care Act fail to address the questions that the states and the policymakers have asked since the law was signed. Medicaid accounts for 1/4 of most state budgets. Governors cannot be expected to plan for major changes and have legislative authority to prepare unless the administration makes clear the basic ground rules. Many state legislatures only meet for a limited time each year, or in the case of my state, they only meet every other year. And that time will be quickly evaporated while they are awaiting instruction on these rules. There's a lot to be sorted out between now and the end of the year. Yeah, there is a lot to be sorted out between now and the end of the year in Congress in general, but in this issue in particular. The uncertain regulatory environment and the overall lack of response from the Department of Health and Human Services is not encouraging to states or to health plans to move forward in cooperation with the agency. And let's be honest, time is running out, and the future of our healthcare system, indeed the future of the health of America's patients, becomes more uncertain every day. It is my hope that this hearing will bring light to the questions that the states and Congress have been asking of the administration for the past 2.5 years, and provide the states with an opportunity to provide their perspective as they attempt to plan for the unknown effects of the Patient Protection and Affordable Care Act. At this point, I'd like to yield the balance of the time to the member from Louisiana, Dr. Cassidy.
Thank you, Dr. Burgess. First, I'd like to thank Mr. Greenstein from my own state for being here and all the other panelists. And I will tell you, I have multiple concerns about how this is being implemented, but I will say it is principally today about how this is going to affect the average American family. There's a McKinsey quarterly report that suggests from February 2011 that about 30% of employers will definitely or probably put their employees in the exchange. Now, when I speak to brokers, they tell me most people will opt for the bronze level, which has a 60% actuarial value. Then I pull up this from ASPE, which is a government agency, which I can't recall the acronym for, in which it shows that roughly 98% of these workers have actuarial values of 80% or more. We've got a law inducing that we put people into an exchange in which the actuarial value of their policy will decrease from 80% to 60%. I'm not quite sure how this serves the average American family. And just to put this in perspective, we know that actuarial value has a $2,000 to $4,000 deductible and an out-of-pocket of $6,350 before it is completely paid for. Now, if we're trading 80% for 60%, I don't see the value for the American worker. And I'd love to discuss today how all this was determined. I yield back. Thank you.
Gentleman yields back his time. The chair now recognizes the ranking member of the subcommittee, Mr. Pallone of New Jersey. 5 minutes for your opening statement, sir.
Thank you, Doctor. I guess I should say Chairman Burgess. Thank you. You like Doctor better? Polls better? Okay. Let me start out by saying that I'm beginning to learn the Republican playbook on the Affordable Care Act. First, they spent a year and a half holding repeal votes, and when that didn't work, they advocated that the Supreme Court would most certainly reverse the law, and of course that didn't happen. And finally, they crossed their fingers and hoped that the president would lose the election. And when all else failed, the next move now is to delay implementation under the guise of lack of information. I want to stress that the president won the election. Implementation is going to move forward, and the landmark health care law will continue to have a positive effect on millions of people's lives. And I just hope that I will be here one day when the Republicans finally realize that we did the right thing. The world is not coming to an end, and in fact, the nation will be better because of the Affordable Care Act. Now, I wanted to clear some things up for the record. One of the critical goals of the Affordable Care Act was to improve access to health care for millions of uninsured and underinsured Americans, because a healthy nation is a successful nation, and it simply is immoral to allow our fellow Americans to suffer because they can't access health insurance. A key feature to accomplish that was expanded Medicaid to help cover millions of low-income Americans. And when the Supreme Court allowed states to choose whether or not to accept the Medicaid expansion provision, Republican governors became nothing but openly hostile. But there is no question that accepting the Medicaid expansion is a good deal for states, because it's a boon to the state's uninsured and its taxpayers. Today we're going to hear from both Maryland and Arkansas, two very different states, about their own cost-benefit analysis that prove this point with dramatic facts and figures. Another critical piece of the ACA is the creation of health insurance exchanges, which beginning in 2014 will provide a stronger marketplace that provides coverage options for millions of Americans. And plenty of states have forged ahead with implementation of their state-based or partnership exchanges. Now, those states that have not are simply using HHS's regulation as an easy excuse. In fact, yesterday, experts consulting with states on exchange development insisted that there's enough information and time to build an exchange. Meanwhile, as we'll hear today from the director of CYO, CSIO, the administration has been steadily working with states, providing flexibility, guidance, and resources. Now, a lot more work needs to be done, and I recognize that challenges do exist, but implementation of the Affordable Care Act puts this nation on a path to better health, and we must not allow states to continue to play politics, which is what some are doing. I expect a lively discussion today, so I appreciate the witnesses' participation. I did want to yield initially to the gentleman from Michigan, Chairman Dingell.
Mr. Chairman, I thank my good friend, and I commend you, Mr. Chairman, for holding this hearing today. In my entire career, I've fought to secure the affordable quality health care our citizens deserve and need. The passage of the Affordable Care Act by the House and Senate, ratification by the President, and subsequent upholding of the law by the Supreme Court brought to fruition a dream that began with my father long before me. The health insurance exchanges and Medicaid expansion are two fundamental provisions of ACA that will achieve our goal of providing affordable health care of high quality to every American. Though the exchange patients and small businesses will be able to easily shop for a health plan that best suits their needs, and the Medicaid expansion will provide millions of uninsured Americans with access to our nation's world-class health care system, which heretofore has lacked a means of paying for it. Therefore, it is critical that we get them right, and I hope that this hearing will enable us to do so.
The gentleman yields back. The chair now recognizes the gentleman from Georgia, Dr. Gingrey, for the purposes of an opening statement.
Mr. Chairman, I thank you. What the distinguished member from Michigan didn't say was that the Obamacare bill will cost $1.7 trillion and result in increased cost of health care, and it does not bring it down. So I find it remarkable, frankly, that 33 months after the passage of this bill, PPACA, a hearing like this is even necessary. We have states, including my own of Georgia, still looking for direction from HHS on provisions that come into effect within the next year. This type of uncertainty makes it impossible for states to successfully budget for the future. What's more, state officials are left with no good options as HHS imposes arbitrary deadlines on them in regard to creation of the exchanges. That's why our state of Georgia, our governor, Governor Deal, who served on this committee and indeed was chairman of this health subcommittee, has rejected the idea of the state of Georgia setting up its own exchange because the restrictions, the handcuffs that are put on the states by HHS just almost make it prohibitive. And the same thing in regard to Medicaid expansion. Our state has taken the option, and I think Governor Deal is correct in doing this, and not expanded Medicaid because of the bottom line cost to the state over an extended period of time. Unfortunately, this hearing today is very much needed. I hope that we are able to find some real answers from CMS which allow our states to indeed plan for the future. And with that, Mr. Chairman, if there's anyone on our side that would like to have time yielded, I'll be happy to do that. Otherwise, I'll yield the balance back.
Right. Seeing none, the gentleman yields back. The chair recognizes the ranking member of the full committee, the Honorable Mr. Waxman of California, for purposes of an opening statement.
Thank you, Mr. Chairman. In March of 2010, after decades of trying, Congress finally passed landmark legislation that extends access to affordable, quality health insurance to all Americans. And since then, the law has already provided remarkable benefits for American families. It's allowed over 6 million young adults to stay on their parents' insurance. It has extended a lifeline in the form of pre-existing coverage insurance plan to over 90,000 people. It's lowered prescription drug costs for 5.5 million seniors and people with disabilities. It has given 86 million people in the private market and in Medicare access to preventive health benefits at no cost. And it has eliminated lifetime insurance company limits on coverage for 105 million individuals. This is an outstanding beginning, and now we stand on the threshold of full implementation. Despite the law's many benefits, it has faced united opposition from the Republican Party since the day it has passed. There have been over 30 votes to repeal this law. There have been numerous court challenges to the law. There are states that have steadfastly refused to move forward to assure smooth and effective implementation. Yet none of these efforts have been successful. The House votes proved to be partisan political posturing, and the Supreme Court declared the law constitutional. Let's be clear. The Affordable Care Act is the law of the land. We should all be united in seeing that its implementation works. As we will hear today, HHS and CMS have done their job. They have provided a constant stream of assistance and information to those taking steps to make this law their own. For some states, no information will ever be enough, and that's the tragedy of politicizing a law that will benefit so many Americans. But other states are acting responsibly. Two of those states are here today, and there are many others. Just this week, for example, Nevada's Republican governor announced that Nevada will move forward with Medicaid expansion. The Republican governor of Idaho said the state will set up a state-based exchange. I welcome and look forward to hearing from all of our witnesses. I'm particularly interested in testimony from Dr. Sharfstein from Maryland and Mr. Allison from Arkansas on what they have been able to accomplish with regard to the ACA expansions. And I'd also like to thank Mr. Cohen and Ms. Mann for their work, the work they've already done and the work we expect for them in the future. The Affordable Care Act is a solid law that will improve our nation's health and health system for decades to come. Let's move forward and work together to implement it efficiently and effectively. Why do we have to have this political fight over and over again? We have a law that's doing good already. It's going to do so much more if we make it work effectively, and it's time to stop the fighting about it and work together. I'd like to now yield the rest of my time to Representative Baldwin from Wisconsin.
Thank you, Mr. Waxman, and thank you to our chairman and ranking member Pallone, as well as all of my colleagues on this subcommittee. I want to appreciate your dedication to healthcare issues, and it's been an honor serving with you in the House of Representatives. On the topic before us today, the Affordable Care Act is the law of the land. And it is now time for all of us to come together and put politics aside and make America's new health law work for the American people. And that includes expanding health care coverage through Medicaid to those who need it most. And that includes creating health insurance exchanges that will provide individuals and small businesses with quality, affordable insurance options. If we all do our part, access to affordable health care will be within reach for all Americans and small businesses, strengthening their economic security. To that end, I am pleased to be in the same room today with leaders who are integral to implementing the Affordable Care Act. Our esteemed witnesses from HHS and state officials are making decisions that impact the lives of citizens, citizens who deserve to have us put progress ahead of politics. And I ask that in our discussions today, we keep those Americans in mind. I look forward to your testimony. I thank you for being here and yield back.
Observation for a member this side of the dais is you're already starting to sound like a senator, and you filibustered a little longer than, but notice the chair was very preferential and let you go. I hope the courtesy will be reciprocated when you're in the august higher house. Well, I do want to welcome our, the gentleman's time has expired. I do want to welcome our witnesses here today and do make the observation that there will be a vote on the floor at some point. We generally allow 5 minutes for an opening statement, generally try to be pretty flexible with that. This morning I'm going to ask if you would try to stay within the confines of that time so that when votes come we perhaps could have gotten through the entire panel. We have a single panel today, but it is a large one, but it is a very distinguished one. And our first witness will be Mr. Gary Cohen, who's the director for the Center for Consumer Information and Insurance Oversight at the Centers for Medicare and Medicaid Services in the United States Department of Health and Human Services. We're also joined this morning by Ms. Cindy Mann, who's the Deputy Administrator and Director for the Center for Medicaid and CHIP Services within the Centers for Medicare and Medicaid Services. Very grateful to acknowledge the presence of Mr. Dennis Smith, who is the Secretary of Department of Health Services, State of Wisconsin. We're also joined this morning by Mr. Greenstein, Secretary, Department of Health and Hospitals for the State of Louisiana. Mr. Gary Alexander, who is the Secretary of the Department of Public Welfare, the Commonwealth of Pennsylvania. Dr. Sharfstein, Joshua Sharfstein, the Office of Secretary, very familiar to this committee from his time at the FDA, works at the Department of Health and Mental Hygiene in the state of Maryland. We're also very fortunate to have Dr. Andrew Allison, the Director of the Division of Medical Services in the Department of Human Services for the state of Arkansas. Mr. Cohen, sir, we'll begin with you. 5 minutes for your opening statement, sir.
Thank you, Chairman Burgess, Ranking Member Pallone, the members of the Health Subcommittee for having me here today to speak about implementation of the Affordable Insurance Exchanges. I have the privilege of serving as Director of the Center for Consumer Information and Insurance Oversight in the Centers for Medicare and Medicaid Services. I oversee federal implementation of the exchanges as well as many of the provisions of the Affordable Care Act that are working to ensure more Americans have access to affordable, quality health insurance. I am confident that states and the federal government will be ready in 10 months when consumers in all states can begin to apply for quality private health insurance through the Affordable Insurance Exchanges. Whether a state chooses to run its own exchange, partners with CMS, or defers to the federal government to operate an exchange, consumers and small employers in every state and the District of Columbia will be able to shop for, select, and enroll in high-quality, affordable health insurance beginning on October 1st, 2013. This is a groundbreaking time for health care in our country. Many families will have health insurance for the first time, and many people who lost their insurance when they changed jobs or became sick will again have the security of knowing that their health care needs will be met. I know states are ready because they have the information and resources they need to decide whether to establish their own exchange or whether they need the federal government, at least at first, to take on some of the responsibilities of operating the exchange in their state. States that want to move forward are moving forward. For example, on Monday we announced that 6 states have already made enough progress in setting up their own exchanges that we have conditionally approved their plans. While there is more work to do before open enrollment in October, these 6 states, including Maryland, which one of my fellow panelists is representing, have shown that they are on track to meet all exchange deadlines. We are pleased that many states are taking leadership roles in implementing exchanges in their states. That is what the Affordable Care Act envisioned, states taking the lead. We will make more announcements about state progress in the weeks and months to come. We hope every state will take an active role in operating its exchange. Since the enactment of the Affordable Care Act, we have been working hard with states to prepare for the day when exchanges will be open for business. We began issuing guidance for the states about the exchanges over 2 years ago, in November of 2010. Since then, we've released regulations, guidance, and fact sheets, including a final establishment rule and the essential health benefits proposed rule, as well as detailed IT information about the specific processes for implementing exchanges. My office has been in contact with states every day in order to provide technical assistance and answer questions. We've held hundreds of hours of webinars, teleconferences, and meetings, at which thousands of state workers have participated. And states are helping each other as well, sharing many tools and documents with other states to help each other get the job done. In addition to guidance and hand-on assistance, we've been working to ensure that states have the resources they need, starting with exchange planning grants and progressing on to establishment grants. States that were eager to move forward to establish an exchange could qualify for an early innovator grant as early as October 2010, and the general funding for exchange implementation has been available since January of 2011. To date, 34 states and the District of Columbia have received about $2.1 billion in grants to fund their process in building their exchanges. These grants are available through 2014 to help states build exchanges or fund first-year startup activities. In addition, states that choose to partner with the federal government to build their exchange may receive these grants to establish state functions that are performed in support of the federally facilitated exchange. Many states, including the 6 we conditionally approved earlier this week, are moving forward, and we are working to support them. At the same time, we are working with states that want to partner with us by taking on some of the key responsibilities of operating an exchange. And we will be ready to operate a federally facilitated exchange in states that choose not to pursue a state-based or partnership exchange at this time. If a state elects to have a federally facilitated exchange at first, it is not a permanent choice. States may choose to operate a partnership exchange or state-based exchange in 2015 or beyond. Now, in operating the federally facilitated exchange, it is our goal to preserve the traditional state role as insurance regulator and not to duplicate state regulatory activity, while also providing help for consumers based on where they live who have questions while selecting or enrolling in a health plan in their state's exchange. We have made significant progress in developing the IT systems needed for the federally facilitated exchange, including systems for determination of eligibility for tax credits, enrollment in health plans, and operation of the reinsurance, risk adjustment, and risk corridor programs, which will help keep coverage affordable. We are now beginning to test these services so we can be sure they will be up and running in 10 months. Since the federally facilitated exchange will need to interact with state Medicaid and CHIP agencies, we have been working with states on the technical details of those interactions and have held webinars with all states on these issues. States that defer to a federally facilitated exchange will not have to pay for federal operating costs, and those states can apply for federal funding for any state functions that they perform in support of the federally facilitated exchange. This hard work, both in CMS and in the states, is beginning to pay off. As I said, 6 states have already demonstrated their readiness to stand up and operate exchanges. My office stands ready to aid any other states who would also like to move forward in establishing exchanges to offer affordable, accessible, quality, private health insurance for their citizens. Thank you.
Thank you, gentlemen's time has expired. Ms. Mann, you recognize 5 minutes for the purposes of an opening statement.
Thank you. Chairman Burgess, Ranking Member Pallone, and members of the subcommittee for the opportunity to testify today. For Medicaid, the implementation of the Affordable Care Act is occurring in the context of an existing program that is undergoing rapid change. Change is being driven by the broader transformation in the private healthcare marketplace by states that are focused on changing the way the care is delivered and paid for, and by federal action, both legislative action and administrative action. We at CMS have a clear focus on helping state Medicaid programs improve care delivery and reduce costs through those improvements. There is no one-size-fits-all model. Medicaid's flexibility and the fact that it's run by 56 different jurisdictions assure that innovation is unfolding in different ways across the country. With this backdrop, let me turn to the initiatives that are underway to promote timely implementation of the Affordable Care Act and the Medicaid provisions in that act. People are often surprised to learn that Medicaid does not already cover all low-income people. Its coverage of children and pregnant women is robust, and most of its spending is devoted to care provided to the elderly and people with disabilities. But millions of low-income parents are not eligible for Medicaid, and before the new law, other adults weren't eligible at any income level except through a waiver. The Affordable Care Act filled this gap and helps to establish a simplified, coordinated system of coverage. It does so by establishing one application, one set of eligibility rules that will apply to the Medicaid program, to the Children's Health Insurance Program, and to subsidies available on the exchange in the form of the premium tax credit, and by having a coordinated system for determining eligibility. Consumers will be able to apply, be found eligible for the appropriate program, and enroll in a health plan without delay. But, as we all know, much work is needed to implement these changes, and for states to be successful, they do need guidance and support from CMS. We've been working aggressively to provide that guidance and support. In April of 2011, we released a final rule that increased the support we provide for the development and operation of state Medicaid eligibility systems. 48 states and the District of Columbia have received approval for that funding. In March 2012, we issued a final regulation covering all of the major new income rules effective in the Medicaid and CHIP program that will be effective in 2014. And we did that regulation at the same time that my colleagues in CISIO issued their income rules, so that states would have the full array of rules available at the same time as they moved forward to implement. This fall, we released comments for the elements of the new application, and we're continuing to consult with states and others as we finalize that application. We've issued guidance on the Data Services Hub and ways in which state Medicaid and CHIP programs will interface with the hub, as well as with the federally facilitated exchange as applicable in a given state. And last month, we issued guidance on the flexibility states have to construct their Medicaid benefit package that will be available to newly eligible adults. In addition to this guidance, we've been creating and sharing tools that help states move forward. We've shared, for example, a verification plan with states so that they can help construct their verification rules as in the way that they design them to be consistent with our overall regulations. We have sent to each state the net income standards and disregards that will be applicable in their states and that will need to be converted to the new rules. Throughout the years, we have had a particular focus on helping states accelerate their system builds to save time and resources. Through various venues, we are making our development products available to states and facilitated states sharing their system artifacts with each other, with CMS making direct links depending upon a state's design objective and the vendors that they're using. Complementing these efforts, we've conducted more than 20 webinars with states on 2014 implementation and established state operational technical assistance team for each state, which consists of a multidisciplinary team of CMS experts on systems, eligibility, benefits, and outreach. So each state has one-stop shopping in terms of answering the questions that they individually and uniquely have. Since this summer, we've conducted 200 SOTA calls with states. It's important to say that the guidance and tools we've made available and will continue to make available have been created with substantial assistance from states themselves. We have numerous state work groups and learning collaboratives on a wide variety of topics. The vast majority of states, though not every state, has participated in one or more of these work groups. We think states have gotten the value from these work groups. We know we have, and we appreciate their assistance and contribution. The Supreme Court's decision did not alter the importance of any of this work. The decision left intact the provisions of the law other than the penalty provision relating to the new adult coverage. What the court did was to make the decision to take up the Medicaid coverage expansion for low-income adults voluntary with each state. States are considering this important question. Soon after the court's decision, Secretary Sebelius wrote to the governors to say there was no deadline for when a state had to make the decision and that the court's ruling left fully intact the very significant federal financial support available for that expansion. In a second letter, we confirmed to states that not only could they have the decision to decide when to come in and if to come in, but if they did decide to adopt the expansion, they could later drop it. And we also noted that the enhanced federal funding for systems modernization would remain available to states without regard to whether a state decides to expand coverage. In mid-November, we issued further questions and answers, and on December 10th, we issued a comprehensive set of Q's and A's on a range of exchange and Medicaid matters. The releases continue, as does the ongoing intensive technical assistance and support. Many states have been able to take the guidance, the tools, the technical supports we are providing and move forward. This is a big job, and we are very much appreciative of all that needs to get done at the state level. Let me assure you that we are eager to work with every single state, no matter what their current stage of development may be. And I join Gary Cohen in saying that we are confident that every state can be ready in time for open enrollment on October 1st. Thank you.
Time has expired. Let me just note the bells are signaling that the House is in recess, subject to the call of the chair. It's not a vote. So we'll recognize Mr. Smith. 5 minutes, sir.
Thank you, Thank you, Mr. Chairman. It's a pleasure to be with you and all the members of the subcommittee today. I thank Senator-elect Baldwin for being here and congratulate her on her. We look forward to your service in the Senate, ma'am. CMS, I want to preface my remarks. I've got a lengthy statement for the record and really did take my statement from the perspective of implementation. I bring with that perspective two things. First, Wisconsin already has done much of the work that the nation is going to be catching up to. We have 90% insurance coverage in the state, over 90% if you add in the people who are today already eligible for Medicaid. If they simply showed up and enrolled, we would have 93% coverage for the state. We also have I think been one of the leaders in the integrated eligibility systems in which people can apply on the internet as well as by mail, phone, and of course face-to-face. So we've done a lot of the work of what to expect an exchange would be faced with. And I also bring experience from implementation at the federal level. I was at the Centers for Medicare and Medicaid Services shortly after the Medicare Modernization Act of 2003 was passed, so was charged with part of the responsibility of preparing for implementation of the drug benefit. I would say CMS has a much more daunting job today than what we did in 2003, and yet in 2003 we were adjusting for the very last through the very last minute, And in fact, even months into it, we still had state partners assisting the federal government because we couldn't quite pull it off all at once. But at that point in time, we had another eligibility system called the Social Security Administration as a major partner that was trusted by our senior citizens. We had many things that were already intact. We knew exactly who we were enrolling. We were simply extending a new benefit to a set group of people. We knew a lot about their health care. So CMS has a far more daunting job than what we were charged with at that point in time. There are lots of good people doing their very best at CMS. I do not envy them for the job that they have. But from the perspective that I have been looking at this throughout, that we take deadlines seriously. The deadline that states faced was the Secretary of HHS was going to start reviewing states January 2013, as in next month, to see if we were going to be ready. We took that deadline very seriously, and decided a year ago that that job was too big. And I would say today we still do not know who is eligible, who will get paid, how will cost sharing be transferred between the federal government, state plan, to a health plan, or to someone else. We do not, again, all of the rules and everything else, we have still some very fundamental things. At the end of the day, you're trying to connect a buyer to a seller. And the fundamental things that are required to do that are not yet in place. So we would not have been ready to have that review. We took that deadline very seriously. The Wisconsin experience, again, we submitted as part of my statement real-life eligibility standards of what is going to be faced out there in converting to modified adjusted gross income, MAGI. MAGI inherently has marriage penalties involved in it. You are going to have different outcomes for similarly situated households, making the very same income, and you're going to have different outcomes of whether or not different members of the family are going to be eligible for Medicaid, whether they're going to be eligible for the tax credit or not eligible at all. When I think some of those inequities start coming to light, there are going to be a lot of unhappy people. I think in the federal exchange, again, and I gave some of our Wisconsin experience in terms of volume of what needs to be anticipated. We don't know, again, call centers, who's that going to be for, what are the standards to be able to answer the phone in what period of time. The idea that you're going to train a whole set of eligibility workers who are going to know Wisconsin's Medicaid eligibility, it's a little hard to accept that given the short period of time. Again, we're 10 months away. Finally, affordability. With the agreement of our partners at the federal government, we've been, since last July, modeling affordability. That is, we have been applying the percentage of income towards premiums because, again, Wisconsin has already expanded eligibility. We have parents, caretaker adults up to 200% of the federal poverty level, people on transitional medical assistance who have income well above 200% of the federal poverty level. So we've been modeling those premiums. And again, that experience, I think, needs to give everyone pause for what we have found. People at the lower income level, they aren't thinking in terms of percentage of income, they think in dollar amounts. How much money is this going to cost me on a monthly basis? The good news at the lower income levels, we predicted pretty accurately what they were going to be willing to pay. On average, amounts of around $59 a month for their care, for their premium. And again, this is just the premium. This is not cost sharing that's going to be applied on top of that. But when you get above 200% and that dollar amount has now gone above $200 a month, individuals have dropped by half. The law does not determine what affordability is. People will determine what affordability is, and I think it's going to be a vastly different experience. Thank you.
Thank you. Time's expired. Recognize Mr. Greenstein, 5 minutes for purposes of opening statement, sir.
Thank you, and good morning, Vice Chairman Dr. Burgess and Ranking Member Pallone, and the distinguished members of the subcommittee. Thank you for the invitation to testify on Louisiana's position regarding the implementation of the Patient Protection and Affordable Care Act, PPACA, particularly as it relates to exchanges and Medicaid expansion. My name is Bruce Greenstein. I'm the Secretary of the Louisiana Department of Health and Hospitals and Senior Health Policy Advisor to Bobby Jindal. Earlier in my career at CMS during the Bush administration, I oversaw Medicaid programs in the Northeast and led the federal government's efforts to reform the Medicaid programs in several states. In fact, I have two of my previous bosses here on the panel. In my current role, I have broad responsibility over an array of health service areas, including Medicaid, behavioral health, public health, and disability and aging services. Before I begin, I'd like to pause to recognize the position that we're in. It feels somewhat awkward to be here testifying on the implementation of one of the largest expansions of entitlement program in nearly 50 years, at the same time as ongoing discussions about federal spending reductions to avert the fiscal cliff and raising the debt ceiling takes place. It's a little bit of a parallel universe. Nevertheless, we are here, as you know. Louisiana has continually shared its concerns regarding the practical and policy ramifications of PPACA. Our decision not to assume the risk of building a state-based exchange is not the product of political positioning. Rather, it was made after careful analysis of the laws and regulations. Beyond the past and ongoing legal challenges of the law, we have broad concerns about PPACA's policy. While the concept of a health insurance exchange is a good one, the PPACA-defined exchanges provide for rigid federal control over coverage options available to consumers, raising costs and limiting choice. In fact, a study recently released by AHIP and the Louisiana Association of Health Plans estimates that PPACA premium tax will force policyholders in my state to pay over $2,000 more for single coverage and $4,500 more for family coverage for individuals over the next 10 years. Similar increases are noted for small and large group employers. This is a significant burden on individuals and families in Louisiana and across the country. Beyond these concerns, there are major practical and implementation hurdles. With guidance having been largely delayed or altogether missing, the October 1st, 2013 deadline to begin open enrollment seems unrealistic, considering the scope and complexity of building an exchange. The FAQs released earlier this week is certainly helpful, but is simply too little and too late. The state's decision not to build an exchange should not be taken as general unwillingness to tackle a complex reform project. Rather, the number of remaining concerns and unanswered questions simply do not give us the needed confidence. Regardless of the type of exchange that will operate within a state, there are 5 key issues fully outlined in my written testimony that need attention from Congress, and thank you for the time today, and action from HHS, including administrative simplifications and adjustments to make timelines more realistic. In addition to our concerns regarding the exchanges, we have serious reservations about blanket expansion of the existing Medicaid program without fundamental reforms to improve health outcomes and lower costs. While states now have a choice, it is not surprising that many remain reluctant. Even with enhanced federal funding, some organizations have heralded the expansion as, quote, a great bargain for states. However, state leaders must be careful before accepting the long-term liabilities of expanding a 1960s-era entitlement program. A recent Kaiser Family Foundation and Urban Institute report reveals that expansion creates winners and losers among states. Their cost estimates, which we believe actually fail to capture the full administrative costs and other impacts, they vary widely among states. For example, the New England and Mid-Atlantic states combined will save almost $16 billion in state funds over 10 years. At the same time, South Atlantic states will be paying about $22 billion more. Governors in states like Massachusetts, New York, Maryland, and Vermont combined will shift nearly $23 billion of state costs to federal taxpayers. At the same time, my state alone is projected to pay nearly $1.8 billion. And this all comes from the same report. Beyond the cost, we want to make sure we are providing individuals with access to coverage that makes sense for them, that it's cost-effective and gives them access to high-quality services. While groups like those published the report might declare victory through the simple act of handing out a Medicaid card, we know that that is simply not enough. However, I believe this administration and Congress begins to engage with states interested in pursuing market-driven healthcare reform, we can create a more sustainable and effective program. Specifically, these discussions should be driven by several tenets of Medicaid reform that include
eligibility simplification and flexibilities that would allow us to keep families together on one coverage product. These points are fully outlined in my testimony, and again in even more detail in a 31-point report issued by Republican governors last summer. President Obama himself said, "We can't simply put more people into a broken system that doesn't work." He's right. Today's Medicaid model doesn't give states adequate flexibility to improve health outcomes or lower overall costs. Instead of rushing to expand, the administration should first engage in earnest discussion with states like Louisiana that are eager to further reform their existing programs now, rather than spend more money on a rigid and expensive program that will not work for all states. Thank you. That concludes my testimony. I look forward to questions at the appropriate time.
Thank you. Time has expired. Would you recognize Mr. Alexander 5 minutes for purpose of opening statement?
Good morning, Vice Chairman Burgess, Ranking Member Pallone, and members of the committee. My name is Gary Alexander, and I am the Secretary of Public Welfare for the Commonwealth of Pennsylvania. Thank you for asking me to discuss the operational implementation impact of the Affordable Care Act on the Commonwealth, and I encourage you to review my entire printed testimony. We in the Commonwealth have never witnessed a law so vast with such demands on state resources and lack of federal guidance. The ACA is not just about the expansion of Medicaid or establishing an insurance exchange. It is about the hundreds of federal mandates and procedural requirements that have escaped public attention, but which we must, by law, obey. The fine print of this legislation is so complex, even the federal government struggles to understand it. Consequently, the states cannot fully understand the law's impact on finances, staffing requirements, systems changes, and operations. In short, this law completely overwhelms society's safety net for the needy. Here are just a few of the problems in Pennsylvania created by the ACA. The law mandates that we expand our provider enrollment system to check with our Medicare data. Medicare databases, however, cannot handle automated changes. We will have to add staff resources to respond to 100,000 inquiries every month. We are mandated to create separate databases to accommodate IRS exchanges, and some databases, such as the federal death master file, we have not been given access to. The ACA mandates that we adopt passive Medicaid renewals, radically changing Pennsylvania's tailor-made renewal systems that took years to refine and perfect. Unlike today, the ACA verification system will not be coordinated with other welfare programs, creating eligibility verification issues. The ACA mandates that we use the National Correct Coding Initiative. Pennsylvania already performs this task through ClaimCheck, a federally approved system that cost Pennsylvania $12 million to develop. The difference now is that the new system will be micromanaged by the federal government. The ACA mandates that we create new transaction methods for claim status and eligibility verifications. Our technology is more advanced than what is mandated, and no one will use the outmoded ACA method. But CMS has told us that the law requires us to develop it anyway. The ACA mandates that states implement the modified adjusted gross income methodology to determine Medicaid eligibility by 2014. This mandate requires extensive eligibility changes and enhancements. That timeline is much too short for large IT system changes, which will prevent us from developing a system that delivers the best value to the taxpayers. This one change will cost the Commonwealth $250 million. The ACA mandates that states have an HHS-approved single streamlined application. Pennsylvania already has one. We are struggling to include the changes and enhancements necessary to incorporate MAGI rules or federal data. The ACA mandates that we use Medicaid to cover the health care needs of children between the ages of 6 and 18 living in households with incomes between 100 and 133% of the federal poverty level. Pennsylvania already provides health coverage for these children through CHIP, a much less costly program. The federal government is thus mandating that we switch to a more costly and less inefficient program. The ACA mandates that we cannot use asset tests, a welfare eligibility tool. When we removed the asset limit test for food stamps, we ended up with lottery winners on the program. We have since reinstituted the asset limit test, but we are precluded from considering this tool for Medicaid. The ACA allows hospitals to do presumptive eligibility determinations for Medicaid. This change could create conflicts of interest. As with many other aspects of the law, CMS has not provided the guidance necessary to implement this requirement. This may leave the states to pick up additional costs. The ACA mandates us to pay primary care physicians Medicare rates. The feds will pay the difference through 2014. Thereafter, the states will be hit with increased costs. Starting in 2015, this change will cost Pennsylvania $45 million a year. To summarize, some of the timelines in the law are unrealistic, and many of the mandates impose unnecessary duplications of effort that some of our states have already achieved. These changes add to our costs, and as mandates often do, impose a one-size-fits-all approach, making our processes less efficient, not more. We are told that the federal government will pay 90% of the cost of the ACA, making this a good deal. That claim overlooks the magnitude of the cost to the states. 10% of a huge number is still a very large number. Beyond that, the magnitude of the federal deficit shakes our confidence that the federal government will be able to fulfill its end of the bargain. The ACA will likely have broader economic impacts that will also directly impact the Commonwealth. We do not have the time to go into these, but we note that businesses are already changing their hiring practices in order to transfer health care costs to the state. Perhaps the largest cost of the ACA is the failure to treat the states as true partners, which was the original intent of the Medicaid program. The federal government now dictates to the states almost every detail of how to run this program. How is that a partnership? Finally, the ACA invites bureaucratic gridlock that works against its desirable goal of securing greater affordable health coverage for more Americans. To fix the problem, states and localities must be engaged and viewed as partners to create innovative solutions. There is a great deal of work to be done to make this law more reasonable and less burdensome for states, businesses, and all Americans. Thank you.
The gentleman's time's expired. To recognize Dr. Sharfstein, 5 minutes for the purpose of an opening statement, sir.
Thank you. Good morning, Chairman Burgess, Ranking Member Pallone, members of the Health Subcommittee. I am Dr. Joshua Sharfstein, Secretary of the Maryland Department of Health and Mental Hygiene. In this position, I oversee our state's Medicaid program, and I also serve as chair of the board of the Maryland Health Benefit Exchange. I'm grateful for the opportunity this morning to speak with you about the implementation of the Affordable Care Act in Maryland. I'm also a pediatrician, and with respect to the last 3 speakers, all my distinguished colleagues from other states, I think I am the answer to the Sesame Street question of which one of these is not like the other. My testimony today will include 1, background on the key elements of Maryland's healthcare system and the importance of improved access to care and cost control, 2, a description of how broad public engagement has guided Maryland's process implementing the Affordable Care Act, 3, specific details on how Maryland, with support of HHS, is customizing the tools in the new law, and 4, a summary of the economic value of healthcare reform implementation in our state. So first, a little background. Over the course of several decades, Maryland has pursued innovation in healthcare financing and insurance markets to expand access to care, control costs, and promote health. Important aspects of Maryland's system include a unique all-payer approach to hospital payment, a small group market that has modified community rating and serves more than 400,000 Marylanders, a high-risk pool, a health information exchange that includes data from all hospitals and allows doctors to have access to help patients to records at the point of care, an all-payer pilot for medical homes to improve primary care, and a Medicaid and CHIP program that covers children up to 300% of the federal poverty line and expanded in 2008 to include parents of dependent children with incomes up to 116% of poverty. Now, I came on board a couple years after that expansion, and I met some of the more than 97,000 Maryland parents who were covered. And I heard how the coverage allowed them to get back to work, to get over injuries that had happened. And I've met one, like the mother on the Eastern Shore, who said that because of coverage, she now, if I have to pick up a prescription, it's not I'm going to have to have the money. I'm not going to have the money. I'm going to have to take it away from groceries. You know, hearing that from somebody where they don't have to take money from groceries in order to pay for health care is something that, you know, we deal with all the time at the state level. And we're really, I think it was the legacy of expanding Medicaid and having it be positive for the state that kind of overshadowed the implementation and kind of was what happened right before the Affordable Care Act passed. Now, despite this progress, major challenges face our healthcare system, challenges that are common to many states, including significant numbers of citizens who are uninsured, substantial disparities in healthcare, rising healthcare costs. So the second thing I'd like to talk about is public engagement in the state. From the day after the Affordable Care Act was signed, Maryland has been working with hundreds of interested people from doctors, hospitals, insurance brokers, businesses, and others, carriers, to design and think through how this set of tools could work for the state. That has included an early consensus that it made sense for Maryland to operate its own health insurance exchange, expand Medicaid, and take advantage of other options within the law. There was wide understanding that the various aspects of the law that included allowing kids to stay on their parents' coverage, improving seniors' access to prescription drugs, also provided great benefits to the state. There was a major report in 2011 that led to the exchange getting established in the legislative session. There are 9 members of the board, including 6 public members, and we have had more than 6 advisory committees with all sorts of representation and engagement across the state. They have met dozens of times. We have had numerous public input sessions, and that led to a second law that passed in 2012 that adopted a series of recommendations, 27 recommendations on how to structure the exchange. All these things were up to Maryland under the way the law was structured. We've made multiple decisions to tailor the law. These include allowing insurance brokers to sell inside at the exchange and continue to be paid directly by carriers like they are now, selling adult dental plans as an option for participants, designing the Maryland Health Connection as a consumer portal for access. And today, Marylanders can send a text message of connected to be notified when coverage is available. We've been customizing Medicaid, including women in private health plans who become newly eligible for Medicaid to stay in their private plans while having Medicaid dollars pay for their premiums. And in making all these individual decisions, and there are many more in my written testimony, we've had tremendous support from both SOCIO and Medicaid as part of the regular process that they use to engage with state officials. And that has extended across into the development of an integrated IT system, which we've been working on for the last 2 years and will really be a leap forward for the state in terms of access to care and coverage. The last thing I just wanted to mention is that there was an independent economic analysis by the University of Maryland, Baltimore County on the impact of healthcare reform implementation in Maryland. And the study found that implementation would benefit the state economy by about $3 billion per year and create more than 26,000 jobs. It would benefit the state's budget by more than $600 million through 2020 through a series of mechanisms that are described in the testimony, and that it would generate more than $800 million in additional tax revenue just because of the economic activity. This incoming revenue exceeds the state cost of the Medicaid expansion, both considering the direct expansion and the potential woodwork effect. So I go around the state talking about all this work that's being done in the state, and people don't ask me about the rules and the guidance and our decisions. They ask me about when help is coming. And we're really excited for this to really launch next year. Thank you.
Time has expired. We'll note that there is a vote on the floor. I believe, though, we have time for Dr. Allison to go ahead with your 5 minutes, at which time we may take a brief recess for votes. So proceed, sir.
Thank you, Mr. Chairman. My name is Andy Allison. I'm the Medicaid Director in Arkansas. I'm also the President of the National Association of Medicaid Directors. I appreciate the committee's invitation to Arkansas and to other states represented on this panel to hear about these important issues. My written testimony, which I've submitted, addresses the 2 main challenges that Medicaid faces today. Foremost is the challenge of the fiscal duress brought on by long-term rates of growth in the Medicaid program, and also by the loss to our tax base suffered as a result of the economic shift that occurred in this country beginning in 2008. The second challenge is really an opportunity, and that is the option for states created in the Affordable Care Act to extend health insurance coverage to poverty-level adults through the Medicaid program. I want to focus my brief remarks this morning on the decision Arkansas faces about whether to take up this option. Governor Beebe expressed his support for the Medicaid expansion this summer. His decision came after CMS confirmed that the expansion remains optional and could be revoked in the future. His support for the expansion is driven by the benefits it would provide to state taxpayers, for the state's safety net, especially hospitals, and to the beneficiaries of the expansion themselves. Arkansas has a great many low-income, uninsured adults, and we know that Medicaid saves lives, it improves health, and it provides financial protection. The decision of whether to expand Medicaid in Arkansas now rests with its General Assembly, who meet beginning in January for 3 months. A supermajority, a 75% vote, is required to appropriate funds in Arkansas, regardless of their source. This is the challenge. The legislature's decision may rest heavily on the financial implications of expansion for the state. Arkansas's estimates of the size of the Medicaid expansion use as a starting point the Urban Institute's March 2011 state-level projections of the expansion. To those estimates, Arkansas added both costs and enrollees. The estimates include some crowd-out of private insurance, include the woodwork effect. Current eligibles represent about 14% of the expected new enrollment. It also includes the added administrative costs. Overall, the gross costs of the expansion total about $900 million per year, including both federal and state payments. But there are also expected savings for the state of Arkansas associated with the expansion. The first source of savings stem from our expectation that a number of populations currently served through traditional Medicaid will migrate or will otherwise transition into the new expansion group of eligibles, thereby qualifying for a much higher federal match rate. Key examples are individuals who currently enroll in Medicaid because of pregnancy or because they've suffered a catastrophic, high-cost medical event. In the future, these populations will already have health insurance when these changes in their health status occur, and there'll be no reason for them to switch to the old eligibility categories, which carry with them a much lower federal match rate. The second source of savings to the state is a reduction in state spending on uncompensated care. If Medicaid expansion is approved, more than 200,000 additional Arkansans will have a payer for their health care. Consequently, uncompensated care provided by state programs outside of Medicaid should decline significantly. Program areas affected include health costs at the Department of Corrections, as well as state subsidies to community health centers, community mental health centers, and public hospitals. Finally, because of the unusual nature and size of the optional Medicaid expansion, Arkansas is making the unusual decision to consider its macroeconomic impact. If the state legislature approves the expansion, federal Medicaid payments to the state are expected to grow by around $800 million per year. Given Arkansas's small size versus the federal tax base, Arkansas assumes in its estimates that federal Medicaid payments for the expansion will come from taxpayers in other states. Put simply, Arkansas's economy will be hundreds of millions of dollars larger if it chooses to expand Medicaid, and this difference in the state's tax base will have some impact on tax revenue. All told, we estimate that the fiscal benefits will outweigh the costs, and the expansion on net is expected to save or increase state tax dollars by $44 million in fiscal year 14, $115 million in state fiscal year 15, and about $700 million between now and 2025. Thank you, Mr. Chairman.
Gentleman's time has expired. Would note that there is still over 7 minutes left on the vote on the House floor, so if it's agreeable with everyone, we will start with questions. I would ask the members who feel it necessary to leave because they are so slow that it takes them 7 minutes or over 7 minutes to get to the floor, that we do leave quietly. But the committee will remain in session, and then we will recess when there is literally no time left on the votes. So I'll start with myself and Director Cohen. If I could, sir, I'd ask you that on November 26th of this year, Health and Human Services released the long-awaited rule detailing the essential health benefits that must be covered by any health plan offering a plan in the PPACA exchange. We all understand this rule has far-reaching consequences on healthcare premiums, benefits that must be provided to those newly eligible for Medicaid, and federal and state budgets. Now, according to the notice in the Federal Register, the rule was approved at the Center for Medicare and Medicaid Services by Administrator Tanover on August 1st of 2012. That's 3 months before. Yet the rule did not receive approval from Secretary Sebelius and the Office of Management of the Budget until 2 weeks ago. So what this committee would like to know is, why did it take nearly 3 months for the administration staff to conduct technical work and review, and yet the public will have only 4 weeks to review during this period of public comment on the rule that was issued on November 26th? And I would also note that this is a time of year where people's focus is generally on things other than long-awaited rules. So can you speak to that, sir?
Thank you, Chairman Burgess. I'd be happy to. You know, we put out a bulletin on the essential health benefits quite some time ago and got comment on that bulletin. And so the public and interested parties had an opportunity to provide comment on essential health benefits before the proposed rule was put out. There were some changes in the proposed rule from what had been in the bulletin, but by and large, what's in the bulletin is what's in the proposed rule. So actually, I think there's been ample opportunity for the public to comment on the rule.
Well,
and they'll have the additional formal comment period, as you mentioned.
So it's your opinion that Wisconsin, Pennsylvania, and Louisiana had actually, during that 3-month hiatus from the time the rule left HHS and circulated through OMB and came back, they actually knew what the rule was going to be and could be confident that they knew what the rule was going to be and could begin to make their plans accordingly?
They had the bulletin which laid out our approach to essential health benefits using the benchmark approach, which basically said, as the law does, that essential health benefits are based on what's in a typical employer plan, and they knew that the state had the option to choose from a range of available benchmark plans. Yes, they knew that.
All right, I didn't plan to ask this question, Mr. Smith. Can you tell us, was Wisconsin absolutely confident that what came out in August and was circulated in a bulletin or a pamphlet was going to be what the rule eventually would be?
Well, again, I think we still have questions about what the essential health benefit package is.
Thank you.
Quick example.
I accept that as your answer. That's going to be a no. So let me just ask you, Mr. Cohen, on November 20th, paper that I don't normally read, but it's called the New York Times, some people have heard of it, published an article by Robert Pear that the essential health benefits rule had been delayed, I'm quoting here, had been delayed as the administration tried to avoid stirring up criticism from lobbyists and interest groups in the final weeks of the presidential campaign, close quote. Now, that is accurate that there was a presidential election between August 1st of 2012 and November 26th of 2012. That's a fair statement, is it not?
Yes, I believe President Obama was reelected.
Well, that being the case, was the rule delayed so as not to interfere with that happy occasion that you just referenced?
I'm not aware of what Mr. Pear's sources might be for that, and I'm not aware that that happened, no.
Well, certainly for the, those of us who were preparing to lay down in the Elysian fields the Affordable Care Act, it did strike us as strange that the rule was available for discussion in August, but not published as a rule until after Election Day. And not just in the under the auspices of the Affordable Care Act, there does seem to be a regulatory push now out of several federal agencies to get things moving and up off the deck now that the election is settled. And I know that I'm not cynical, but there are people in Washington who are and would look at that. And again, I don't read that newspaper, but apparently they felt that there was some relationship. 33 months delay on the fundamental rule necessary for the operation of these exchanges does cause some of the people who are cynical in this town to repeatedly ask the question, what's the holdup? And this is an important deal that you all are doing, and it does seem to be, it appears to me that it's possible that these cynical people could be correct, that it was held up for political reasons. So what I'm saying to you is we are going to have a series of questions, and it's too long to go into here, but I would appreciate, it's been hard to get information out of your agency, in all honesty, sir. The governors have had trouble, members of Congress have had trouble. I would appreciate the expeditious handling of those questions when they come to your attention.
We'll do the best we can.
My time has expired.
I think we're out of time. We have a minute. I think we better vote. We got to go vote.
All right, the vote on the floor is a motion to instruct conferees on the National Defense Authorization Act. The committee will stand in recess and will convene immediately after the last vote.
Which one was Jeff? I don't know. Well, you can tell her what's that.
If members will take their seats on the dais, the committee will reconvene. All right, the committee is reconvened, and the chair recognizes the ranking member of the subcommittee, Mr. Pallone of New Jersey. 5 minutes for questions, sir.
Thank you, Mr. Chairman. The title of this hearing is State of Uncertainty, Implementation of PPACA's Exchanges and Medicaid Expansion. I want to say, Mr. Chairman, that I think the title is provocative, and I think it does a disservice to the progress and the people of this country with regard to the ACA. The fact is the ACA has prevailed, and it's the law of the land. Millions of people have already experienced positive changes from the Affordable Care Act, whether it's through the elimination of lifetime limits, the ability to stay on their parents' health insurance plan, coverage of preventative benefits with no cost sharing, lower prescription drug costs, or another provision of this law. In any case, the Affordable Care Act is improving the lives of Americans already. And over the next decade, 30 million Americans who otherwise would be uninsured could have access to health care. Millions more will be put in charge of their health care as opposed to being at the mercy of insurance companies and the arbitrary limits and fine print denying coverage for critical services or overly burdensome cost sharing. And states have the options and flexibility to help make this a reality for their residents, and CMS has been working with those states that have been ready and wanting to move forward and make this work. My questions are to Mr. Cohen and Ms. Mann. Critics have cited a dearth of information, a lack of answers, an inability to move forward. You've heard that from some of the other panelists. Can you talk about your outreach efforts to states, the engagement with them, the types of assistance you've provided over the past 2 years?
Thank you, Ranking Member Pallone. I'm happy to do that. Just in 2012 alone, CSIO has hosted 119 different events of different kinds for states that total approximately 215 hours of technical assistance. We've done 69 webinars that over 3,000 state people have participated in. We've done 48 teleconferences. Over 2,500 state workers have participated in those. And we've held 2 in-person conferences where people have come in, and over 1,000 attendees have come to those. So we've been, in addition to that, we're on the phone literally every day with people from the states, helping them, answering their questions, and enabling them to move forward.
I appreciate it. Ms. Mann, and then I want to ask Mr. Sharfstein.
Sure, thank you, Mr. Pallone. You know, I think it's been a very different experience than past experiences in CMS, where you usually put out guidance, put out regulations, and hope for the best. We've been very aggressive with our partners at CISIO to reach out to states and to bring them into partly our decision-making and certainly their decision-making as they're going forward by topic, by groups of states, as well as very much individually. We do gate reviews on their systems developments individually with states. We do that together with CISIO so that we're providing some coordinated technical assistance and support. We have pulled together work groups and learning collaboratives of groups of similar interests so that we can help them think about how to problem solve with respect to the issues that are upmost in their minds. And we've provided and increasingly are providing different tools for them so that as they're moving forward, looking at our regulations, looking at our guidance, and thinking about how to implement, they have easier ways of doing it than if they just reinvented the wheel and did it on their own.
All right, thank you. Dr. Sharfstein, can you talk about the interactions you've had with the Centers for Consumer Information and Insurance Oversight in preparing your state-based exchange for Maryland?
Sure. We've had a terrific interaction. There are regular opportunities for all states that we have taken advantage of, and we have regular consultation. And what we've been really impressed with is that both CISIO and CMS have really met us where we are on a particular issue. Sometimes it's general help, sometimes it's very, very specific, and they've been really willing to move at the speed that we're moving on a particular issue and work together across organizations. So from Maryland's perspective, the assistance we've gotten from HHS and the spirit of cooperation and support has allowed us to really customize implementation in a way we think works for our state.
Thank you. I'm going to try to get a question into Mr. Allison. Despite claims to the contrary, the ACA was fully paid for when passed, and if repealed, would actually increase this country's budget deficits by more than $100 billion. And the ACA contains strong cost containment measures aimed at reducing healthcare costs the right way by improving care. I was interested in Arkansas's payment reform efforts. It seems aligned with the activities of the Center for Medicare and Medicaid Innovation. Could you tell us a little more about these payment reforms and how that would bring down costs, not just slash benefits or cost shift?
Yes, absolutely. We believe in Arkansas that the incentives that we face and the activities we're engaged in our payment improvement initiative are wholly aligned with the objectives of the Center for Medicare and Medicaid Innovation, CMMI. We're engaged in moving away from fee-for-service in order to pay for outcomes in healthcare instead of the process that we currently pay for. We are paying for team-based outcomes. We're engaged in population-based reforms. We're looking for patient-centered care, and if we look for that, that means we're going to have to pay for it. We haven't done that in the past, and we are engaged in dramatic and sweeping changes, working also with our private health insurance partners in Arkansas. We've worked very closely with CMS to make the first of these changes, implementing in October through our state plan, not through waiver, an incentive-based episodic treatment payment reform that incentivizes for ADHD, for perinatal care, and for upper respiratory infection, concentrated accountability and incentives for team-based care. And that happened very quickly, and we appreciate CMS's support in that.
Thank you.
The gentleman's time has expired. Recognize the gentleman from Illinois, Mr. Shimkus. 5 minutes for your question, sir.
Thank you, Mr. Chairman. Thanks for being here. When you hear that both sides, it's kind of like a Jekyll and Hyde type. Will this turn out to be the Jekyll, or will this turn out to be the Hyde? And I don't think we really know yet, unfortunately. The Patient Protection Affordable Care Act implies that health insurance will be affordable in the exchanges. The claim put forth was that if you like your insurance, you can keep it, and that health care costs would go down. That's how it was sold to us. Most of us, some of us reading the bill, but most of us passing the bill before we could read it. The CMS recently proposed a 3.5% fee on all plans, offering plans in a federal exchange. Are you afraid this fee will get passed on directly to individuals and families purchasing coverage in your state? And this is a question for Mr. Smith, Mr. Greenstein, and Mr. Alexander. And if you could be short, because there's a couple more questions I want.
Well, to be paid on not only onto the purchaser in the exchange, but these also apply to Medicaid managed care plans as well. So there's a direct impact on the state budget for these new fees.
So more costs.
Yes, sir.
Yeah, it puts these plans in a competitive disadvantage as well, and we fully expect that those costs get passed on rather than absorbed with already small margins for the plans that participate, at least in Medicaid managed care.
Great, Mr. Alexander.
The short answer is yes. I think I would concur with my colleagues.
Great. I appreciate the shortness of those answers. Mr. Cohen and Ms. Mann, do you know what our national debt is right now? Just the national debt. It's on every debt website in the world. $16 trillion. Do you know what our deficit spending of this country has been the last 4 years? In essence, how much we have spent more than we've taken in? Is that you don't know? Do you know?
I don't have that information right here.
Okay. Mr. Cohen, do you know?
I don't know the exact number, no.
All right. Well, in 2009, it was 1.4 trillion. In 2010, it was 1.2 trillion. 2011, 1.3 trillion. That's more spending than we've taken in. 2012, 1 trillion. Already this year, first quarter, first 2 months, we've $292 billion more in spending than we've taken in, which if you push that through to the full year, is probably $1.7 trillion additional deficit added to the $16 trillion debt. That's part of this debate because of Medicare and Medicaid or entitlement programs, and that's part of the reason why we're going to be here till Christmas and New Year's and have all these the battles. Let me go to just again for Mr. Smith, Mr. Alexander, Mr. Greenstein. And this is really about the state of Illinois now. Estimates from earlier this year have the state of Illinois unpaid bills growing to $34 billion in 5 years. That will be $2 billion more than Illinois' total projected revenue that year. The biggest problem, can you guess what the biggest problem is, Mr. Smith?
Medicaid.
Mr. Greenstein?
Medicaid.
Mr. Alexander? Illinois Medicaid has been on an unsustainable path for years and expected to increase more than 40% over the next 5 years to about $12 billion by 2017. Overall, this will create an estimated $21 billion in Medicaid payment backlogs. And this figure doesn't even factor in the unknown additional costs from new Medicaid requirements from, what would you guess, Mr. Smith?
Medicaid.
From the new health care
The
law
Affordable Care Act.
bans the Affordable Care Act, Mr. Alexander?
Concur.
What do you believe will be the result for Medicaid providers and patients if these backlogs remain? What do you think, Mr. Smith?
Well, again, I think we've been looking at what happens to the Medicaid rates themselves. We're expecting to have to, again, I know there's a lot of discussion about the FMAP for the newly eligibles, but this affects the entire program. Otherwise, we will not have providers who will see Medicaid payments unless the rates go up.
Mr. Greenstein?
Yeah, I worry about the participation in Medicaid from the provider perspective, but I also worry about programs like education that get crowded out within the context of the state's budget because we continue to consume a greater proportion of the overall budget in our health care costs.
Mr. Alexander?
I concur. The last one, so I guess I say I concur, but I'd like to just add to Mr. Greenstein's that the crowding out of other priorities is extremely important. For Pennsylvania, infrastructure is extremely important in transportation. So, the growth of these programs growing at 8 to 10% while revenues are growing maybe at 2% keep crowding out education, transportation, and thus have a direct impact on jobs.
Thank you very much. Yield back my time, Mr. Chairman.
Thank you, gentlemen, for yielding. Chair now recognizes the gentlelady from California's caps for 5 minutes for the purpose of the question.
Mr. Chairman, is this based on speed? Okay.
The chair recognizes the ranking member of the full committee, Mr. Waxman. I'm sorry, I didn't see you sitting there.
Yeah, thank you, Mr. Chairman. I thought I was next. Medicaid's an expensive program because we have a lot of people who are very poor in this country. And we could save a lot of money if we didn't give them health care. Now, I suppose Mr. Smith, Mr. Greenstein, and Mr. Alexander, you think the way to solve the Medicaid problem is to put in a block grant. Is that correct? Mr. Smith, you like a block grant? Yes or no?
Yes.
Mr. Greenstein?
If given the choice, I would take it gladly.
Yeah, Mr. Alexander?
Absolutely.
Okay, you three would like a block grant on Medicaid. That simply shifts the costs. So the states can cut back on services for these people, and the disabled and poor will go without health care. Your idea is not going to succeed. That was one of the issues in the presidential campaign, and you lost. So we have Medicaid, and let's accept that fact. You're running the programs. You ought to be supporting the program you're running in your states. The Medicaid expansion in the Affordable Care Act is a tremendous step forward for our health care system, and it's going to improve the lives of tens of millions of Americans. The expansion will dramatically reduce uncompensated care costs in states around the country. It'll provide states with an extremely generous enhanced match rate from the federal government. We crafted this piece of Affordable Care Act to ensure that Medicaid expansion would not only be good for Americans' health, but for the health of state budgets. And a new report from the Kaiser Family Foundation shows just how beneficial this expansion will be to states around the country. The report found that over the next decade, with the federal government paying for well over 90% of the cost, Arkansas will reduce its uninsured population by nearly 150,000, Louisiana by 270,000, Maryland by 140,000, Pennsylvania by over 310,000, and Wisconsin by nearly 125,000. I doubt that a block grant would accomplish those goals. The report also found that these states could dramatically reduce uncompensated care costs through the Medicaid expansion. Over 25 million savings in Arkansas, over 260 million savings in Louisiana, nearly $180 million in savings in Maryland, over 875 million in Pennsylvania that would be saved, nearly 250 million in Wisconsin. These are big, staggering, impressive numbers. But even more impressive is the fact that in 2 of the states here today, the report found that given the generous federal match rate expanding Medicaid and dramatically reducing the number of uninsured would actually decrease the state's overall Medicaid budget, saving an additional $250 million in Wisconsin and $1.75 billion in Maryland. Mr. Allison, I assume you could talk about the importance of engaging in a detailed and factual comprehensive analysis of the Medicaid expansion in Arkansas and the conclusions it led you to. You think this is going to be a good deal for your state, don't you?
I believe it's going to be a very good financial deal for the state of Arkansas.
Well, these expansions are going to be a good deal, but it seems to me that the 3 witnesses in the center of the table have an ideological view that they'd like the world redone. Now, the Affordable Care Act is a pretty important piece of legislation, and Dr. Sharfstein, since your exchange planning is well underway, I understand that insurance companies are sending in a great number of letters saying they want to sell insurance in the exchange. And I'm curious to know, are you concerned that insurers won't show up, or you think they are going to show up? What are you seeing so far?
We asked insurers in Maryland to send letters of intent to participate in the exchange, and we've gotten more insurers interested than actually serve the Maryland market now. So we think that under the Affordable Care Act in 2014, it's going to be drawing new insurers in Maryland, including plans that are very focused on better health, improved value, and it's going to be a real positive for the market in the state.
Well, it just shows if we have more insurance companies willing to offer insurance policies, the competitive model for the consumer choice is going to be more successful under those circumstances. I submit that the competitive model that Mr. Greenstein indicated he'd like to see, which is called a consumer market-driven healthcare reform, is not going to work for Medicaid patients. Nobody's going to be vying for those Medicaid patients and all the range of services that Medicaid provides. The ACA has been law for nearly 3 years now. It has an impressive list of accomplishments, and the basic reforms are still ahead of us. After full implementation, over 30 million American uninsured will get quality, affordable care, etc. But the point I want to make is that many of us fear that the purpose of this hearing is simply to say that we can't move forward. We can't implement the law, that somehow we don't have the information needed to do it. That's flat out wrong. It seems to me this is just the latest approach to try to undo the Affordable Care Act. Republicans have failed to repeal the law. They didn't want to pass it in the first place. Then they wanted to repeal it. They didn't win the presidential election, they didn't find that the law was declared unconstitutional. Let's not buy into this next line of attack that the law must be delayed. Let's recognize that we've got a law, whether you would have wanted it or not. It's the law of the land. Many of us think it's going to do a lot of good. We're seeing a great deal of success already. And I think this hearing is just fitting for this Congress. It's the Groundhog Day Congress, over and over and over again. It can't work. We can't do it. We can't afford to cover people. Our debt's too great. Well, let's make this thing work. Thank you, Mr.
Gentleman's
Chairman.
time
You're
has
back my time.
expired.
May I respond, Mr. Chairman?
Please.
Wait a second, Mr. Chairman. If we're going to have the witnesses start responding, then I'm going to be able to respond to them, I presume. My time has expired. I had the opportunity to use my time as I saw fit. And I don't think this is an open-end question to have witnesses respond, unless you guarantee that I can come back and respond to them. If you want to open the hearing up to a two-way exchange, I'm willing to do that, but you do have other members waiting to be recognized.
I do think, as a matter of courtesy, that we ought to allow our witnesses to respond. That's long been the practice in this committee, but as the ranking member sees difficulty with that, we'll recognize Mr. Murphy, and perhaps Mr. Smith. If you'll hold that thought, we'll get a chance for you to visit with us. Mr. Murphy, you recognize 5 minutes for questions, sir.
Thank you, Mr. Chairman. Mr. Alexander from Pennsylvania, and so am I, and you recognize that this is the law of the land, the Affordable Care Act. Am I correct on that?
Yes.
Are you trying to stop or undo its implementation?
I don't think anyone's trying to stop anything.
Thank you.
I think we're trying to make sense of it.
So let me ask you a number of things you said in your testimony. I want to ask you about that. You identified a number of problems that Pennsylvania is having, and certainly the other witnesses are welcome to respond to these too. But a number of those key ones I wanted to ask about. You had mentioned that we have the CHIP program, the Children's Health Insurance Program in Pennsylvania. I know when I was a state senator, worked on that as well. And you feel it actually works in a less costly manner and has good quality in the program. Is this something that you are able to ask, according to the law, are you able to ask for a waiver to use that instead of the other program? Right now as the law stands, do you know?
I don't know of any waiver to be able to make that change.
Is that something you would recommend that Congress address in terms of allowing for waivers?
I think
for
so.
those?
I think if things are working in the state, they should be kept that way, and especially if recipients are happy.
Ms. Mann, are you aware, are states allowed any waivers for programs like that if they have a program they think is working well?
There's a wide range of waivers that are available for states. One of the things about the changes in the law that brings the CHIP kids over into the Medicaid program is right now their younger siblings are already eligible for Medicaid. So one of the reasons for the changes is to put families together. Right now we have children in the same family, same income.
I
They're in
appreciate that.
different
I'm just trying
programs
to bring
depending
people
upon
together.
their age.
I know when we did the prescription drug bill for Medicare, Pennsylvania already had a program for that, and we were able to work in legislation to make sure that they did work smoothly. So that might be something we might want to work on in the future, and I'd certainly hope that you can get together with Mr. Alexander. Mr. Alexander, you also said you can't use an asset test. What do you think is the benefit of having an asset test, and what do you see in the law that restricts that?
Well, an asset test is a program integrity tool to be able to ferret out if families or individuals have high incomes or assets that would, not incomes, but assets that would, that they shouldn't be on the program. So for example,
Such as?
So for example, if somebody, owned a large home and cars and they had these assets or specific accounts, we would be able to utilize them in the same way we do with the food stamp program.
So you would like those same rules to be able to be applied?
It should be an option. It was an option prior, and it should be an option.
Would you see similar things with regard to presumptive eligibility as another way of making sure that people who need these programs are eligible for these
It's
programs?
another program integrity measure to be able to, presumptive eligibility would presume that people are eligible. We still don't have guidance from CMS as to who would be on the hook for that money if these individuals later on are found not eligible. Would the state be paying that bill? Would the federal government be paying that bill? I don't think anybody should be paying that bill.
And I'm assuming you would ask for the same sort of assistance with what you refer to as adoption of passive Medicaid renewals, duplication of efforts, one size fits all. Those are areas that, are you asking Congress, Mr. Secretary, that one of the things that we should do is either find out if we're missing something in the law to clarify that, and in absence of that, to look to this committee to pass some laws or rules that would help you do that, so you're not adding to your costs if you're able to do things better?
I think that would be very helpful. The more you engage the states, the better. We're on the ground. We know how to run these programs, and I think that the more information you have from all of the states be very important. The purpose in these programs is to provide quality care to low-income individuals, and we at the state level have to be vigilant in terms of being able to prevent people that have the ways and means to provide for themselves.
Thank you. Mr. Smith, do you have any comments on those questions?
I would agree with Secretary Alexander. I think he summarized them very well. Thank you.
Thank you. The other witness, Ms. Greenstein?
Sure. I would echo that sentiment in that every day with a finite budget, at least in our state, we don't have the option to run large deficits, so we have to balance our budget every year. And that if there are resource decisions to make on how we allocate those resources, we would like to see those resources focused on the people that need them the most, rather than those that have the means to pay for part of the care themselves.
Thank you. I see I'm out of time, but Mr. Chairman, I would hope you would ask the witnesses who have some of these specific recommendations that we might do some legislative actions that they would submit to you in writing, some of those recommendations, and with the witnesses would do that. And without a yield back, sir.
The record will remain open for 5 days, 5 legislative days for witnesses to submit. Chair recognizes Chairman Emeritus of the full committee, Mr. Dingell.
Mr. Chairman, I thank you for your courtesy. Mr. Cohen, we appreciate you being here this morning, and I have some following questions to be answered yes or no. Recently, we've heard a lot of talk about the $63 ACA fee that will go into the reinsurance fund. In your opinion, is this a tax, yes or no?
No.
It is not in the U.S. Internal Revenue Code, is that right?
Correct.
So we can call this a fee as opposed to a tax, is that right?
Yes.
Now, CMS had the authority to set this fee through Section 1341 of ACA. Is that true?
Yes.
Now, Mr. Cohen, this section does not set the per insured fee. Instead, it sets out a total amount to be raised. Is that right?
Yes.
This fee will be $63 in 2014, lower for 2015 and 2016. Is it true that this fee is short-term and will end after the total amount is realized in 3 years?
Yes.
Now, Mr. Cohen, I happen to be just a poor Polish lawyer from Detroit, so I want to make sure I understand this correctly. The fee goes into a reinsurance fund that will stabilize the premium costs in individual insurance markets. Is that correct?
Yes.
Now, Mr. Cohen, this will help ACA to provide funds to insurance companies who deal with a large amount of and a large number of vulnerable populations, those with serious pre-existing conditions and high health care costs. Is that right?
Yes.
So essentially it's a reinsurance fund. Is that right?
It is.
Now, Mr. Cohen, this fee will lower insurance premiums in the individual market because insurers will not have to factor in the costs of disproportionate high costs of enrollment of high-risk patients. Is that correct?
Yes.
And isn't it true that this, in turn, will benefit employer plans and employees with stable prices because they will no longer have to pay for the cost shift that occurs when there are people out there without the insurance or the means to pay for health care? Yes or no?
Yes, it will.
Now, so at the end of the day, this fee guarantees those in dire need of insurance, our constituents with pre-existing conditions, are covered and by so doing, we actually lower and stabilize the cost of health care for all of our citizens. Is this correct?
Yes.
Thank you, Mr. Cohen. Now, I want to say a few things, Mr. Chairman. We have the law of the land, the Affordable Care Act, and I'm hearing no end of carping and complaining about it. But the hard, simple fact of the matter is that the health care costs of this country are running away from us and will destitute the nation. We have to do something to get it dealt with. We have to get all the people covered, and we have to see to it that we deal with the problems of inadequate health care for our people in the future. This is a very serious matter. It is going to attack almost every single program, including Medicare and Medicaid, and the costs that the states are being compelled to meet with regard to Medicaid. I find myself very distressed because I feel that I'm kind of in the company of a bunch of people who are looking at the donut and seeing only the hole. You know, we confront a situation where we have to address these problems by making intelligent investments. And one of the things that I find that terrifies me is we've got a lot of people in this country who can look and who can see the cost of everything, but they can't see the value of anything. And the value of what we're trying to do here is to see to it that everybody has health care, to see to it that the health care of this country is affordable and it's available to all of our people, and to see to it that the people of this country have a system which makes available to the ordinary citizen the right of health care. And it is, in my view, a right. It is not a privilege. There are a lot of people around here who seem to look at it as a privilege. And they'll do everything they can to save money on seeing to it that some other poor bastard doesn't have health care. So I'm hopeful that we will look at this as an investment in the future of the country, and that we'll try and do something to see to it that the health care in this country, which potentially is the greatest and the best in the world, is shared around amongst the people, and that they're not denied this, and they're not dying because they don't have health care. So I hope that this hearing will lead us to an understanding of these points, and I yield back the balance of my time.
The gentleman yields back. This time, recognize gentleman from Louisiana, Dr. Cassidy. 5 minutes, your questions.
Just so folks know, we've had some effectively implied allegations that some of us don't care about access to affordable care. I actually am a doctor who Tuesday and Monday will be in a safety net hospital for the uninsured, or the poorly insured, which includes Medicaid. And so just let's get that on the record. I got lots of questions, so hopefully I can run over. Mr. Cohen, I'm not clear. Will CMS propose something about allowing premiums to go into a health savings account? Will that money of the premium which goes into the health savings account, will that be considered as regards the MLR? You follow what I'm saying? So medical loss ratio, will that, please?
Yes, it will be considered first dollar coverage for purposes of MLR, to the extent that it's spent.
So if someone does not spend their money in their health savings account, the insurance company does not get credit for an expenditure as regards the MLR?
That's right.
So if somebody is frugal and doesn't go and buy overpriced goods, rather does preventive medicine on their own, takes care of themselves, keeps their weight down, et cetera, the insurance company will be penalized?
No, they're not penalized.
But it
just
won't
doesn't
count against their MLR, and you're going to come back and take a portion of that, and you're going to come back and make them rebate that cost. Is that correct?
The medical loss ratio provision, or the 80-20 rule, requires that insurance companies spend 80 cents of every premium dollar on actual health care, and if the money isn't spent, it wasn't spent.
The deposit in the HSA does not account as an expenditure. It's only if the patient spends the money.
Right.
So we're trying to hold down costs, but we're basically putting in incentives to spend the money. By the way, it's hard to keep a straight face when Mr. Waxman speaks about access to affordable care. The only thing I've heard about this bill is that premiums have gone up by $2,500 since it was passed. It's kind of curious, isn't it? Dr. Sharfstein, only 65% of doctors in Maryland accept Medicaid patients. I gather that's a statistic that I can give you the source from, Health Affairs. How many of those Medicaid patients unable to find a primary care doctor seek their care in an emergency room? Do we know those statistics? Some states do know that statistic.
We, I don't know if I have a specific answer to that.
Then let me go on, because I have limited time. I don't mean to be rude to any of you. I apologize. Now, the issue is, in Maryland Medicaid, I presume there is no deductible.
Absolutely.
Correct.
Now, y'all guys make out like a bandit. If I was a big blue state, I'd be all for this expansion because according to Kaiser Family Foundation, you're going to save $500 million over 10 years. Why wouldn't you be for it? But let me put myself in the role of someone that I might be seeing Tuesday morning in a hospital if I were in Maryland instead of Louisiana. You're making 140% of federal poverty level. The state grabs the money, man, we're glad, it helps our budget. But now I'm on the exchange. I have a $2,000 deductible. As Mr. Smith points out, I'm paying $600 a year in a premium. Do we really think that family at 140% of federal poverty can afford that $2,000 deductible?
Well, from my perspective, this has a lot to do with compared to what? Someone at
Compared to your current Medicaid plan.
140%, there's no access to Medicaid. So they have no.
Oh, I thought you said in your testimony that you have up to 200% of poverty level in your Medicaid plan.
No, we do not.
Oh, then I misread that.
For an adult. So they have no access. So we're able to give them affordable access through a subsidy.
Now, okay, then let's just take that person at 140%. Do we really think they're going to be able to afford that $2,000 deductible? By the way, if I was an insurance plan, I'd be moving to your state too. Now we have the federal government telling you you have to buy insurance. It isn't competition, it's a forced market. Do we really think that that family at 140% of federal poverty can afford that $2,000 deductible?
Well, we certainly think that there's a lot of value for them, and part of what we're going to be doing and what we're working with so many people in Maryland is to figure out how to develop an outreach plan that engages.
Even though it's going to cost them $2,000, I tell you, I like Mr. Smith's line, it's not a percentage, it is the dollar amount. And when you're at 140% of federal poverty, $2,000 might as well be $50,000.
It's not every family that has to pay $2,000.
Only if they access the insurance portion. Let me go to Mr. Allison, Dr. Allison, I'm sorry. Dr. Allison, in your testimony, you mentioned that the state of Arkansas will have to come up with $500 million between January and June 14 to implement this plan. Is that correct?
That's not correct, sir.
That's your testimony.
That's not what the testimony says. The testimony says that the legislature will have to appropriate $500 million for the second half of state fiscal year 2014. That would include, in this case, almost all federal funding.
So that's going to be all federal dollars? It won't be state dollars?
Almost all federal funding.
Okay, so they have to appropriate federal dollars?
Correct.
Okay. That's interesting. And the economic aspect of this, by the way, let me just point out, if I may go just a second longer, the Kaiser Family Foundation study that Mr. Waxman proposed is going to cost Louisiana $1.8 billion over 10 years, Arkansas $1.2 billion, and that's assuming that we don't have to raise taxes on the federal or state taxpayer to pay for this extra money, which is an assumption which just seems a little silly. I'm over time. I yield back. Thank you.
Thank the gentleman for yielding back. The chair now recognizes the gentlelady from California, Ms. Capps. 5 minutes for the purposes of questions.
Thank you, Mr. Chairman, and to all of our witnesses, thank you for your testimony today and for your availability. I want to give you, Mr. Cohen, just a minute to respond to the previous questioner. Mr. Cassidy asked about the medical loss ratio and the HSA contributions, but if you could be very brief.
So what we've said is that the 80-20 rule says insurance companies have to spend 80 cents of every premium dollar on care. So to the extent that the HSA dollars are actually expended, they will be counted towards that 80 cents that the insurance company has to spend.
Thank you very much. I want to address some questions to you, Ms. Mann. The Affordable Care Act includes a provision that will bump up the payment for primary care providers and Medicaid to the rates we currently pay through Medicare. On average, this will improve primary care reimbursement by 67% on average nationally. In my state of California, the increase will be even more important, 113% increase for current reimbursement. Could you explain why raising primary care reimbursement for Medicaid providers is so important and how this will benefit patients, but also the healthcare system as a whole, the role it plays?
Of course, in the Medicaid program and in the changes going on in the healthcare marketplace more generally, there is real appreciation of the value of primary care, and to avoid unnecessary high utilization of specialty care, to avoid catastrophic care, people need regular primary care, preventive care. And what this primary care boost does is encourage more primary care practitioners to enroll in the Medicaid program, participate in the Medicaid program, and to provide a greater share potentially of their hours of service to Medicaid beneficiaries. So we're very excited about the opportunity to expand and deepen access, particularly around primary care, and to reduce costs overall as a result.
Absolutely. I share your belief in that. As I understand it, the research on provider rates shows that states with higher rates have greater numbers of providers accepting new patients, and that states that have increased their rates have seen more providers willing to increase their participation. Given that, do you think that increasing rates to Medicare levels for primary care physicians will both increase the number of physicians participating in the program and allow some who are already participating to increase the number of Medicaid patients they see? That's a big problem right now.
I do think it will boost participation. I think there's a general agreement that it will boost participation. I do want to say that I think that rates are one of many factors that help us make sure we have a good provider participation in the program. But this will go a long way to assure greater participation, particularly in the needed area of primary care.
Thank you. And as you may know, there's a lot of talk from some in Congress that the Medicaid primary care payment bump should be used to pay for SGR. I have consistently voted to get rid of the SGR, and we even did so in the House version of healthcare reform. But this pay-for idea is, frankly, in my opinion, foolish. This would literally incentivize providers to take care of our seniors at the expense of the poor. And the healthcare community, providers and patients alike, agree. You may have a comment on this, or I can move on and ask another question. You
appreciate your support for assuring good primary care in the Medicaid program. Thank you.
Now, when states expand Medicaid under the Affordable Care Act, they pull in federal dollars to provide health insurance to millions of people who don't have it now. Right now, these uninsured people are relying on health care, safety net providers, and programs that are paid for by state dollars. Many of our states can't afford to do this, and they're cutting. Won't states be able to actually save some significant dollars in their state health budgets on programs that pay for uncompensated care, on mental health savings, et cetera? In fact, the net cost to state budgets of expanding Medicaid could be quite negligible, or even a net gain. Is that correct?
I think that's absolutely correct. Different states have done their studies, and different organizations have done studies, and it obviously varies by state, but the amount of the increase overall, under the Kaiser study that people have been citing today, of the Medicaid expansion, just looking at the expansion, is less than 0.5% in terms of the impact on state budgets, notwithstanding the big change in the number of people who would gain coverage. But then, as you say, there's offsetting savings. There's uncompensated care will be reduced, and Governor Sandoval came out this week and supported the Medicaid expansion. One of the things he cited in Nevada is the reduction in state funding for mental health services that will no longer be necessary. Those were funded by the state to fill in the gap, and that gap will be filled through the Medicaid expansion.
Thank you very much for your answering. And Mr. Chairman, as I close, I ask unanimous consent to enter the following letters into the record opposing that this pay-for idea. Letter from the family and children's health groups and providers, a letter from the majority of our nation's physicians, and a letter from the California Children's Hospitals. As requested, to be submitted.
Without objection, so ordered. I would also likewise like to insert into the record a letter from the governor of my state. We've had several good states testify here today. Governor Perry also wrote a letter on this subject, and I would like to have that made as part of the record as well. So without objection, so ordered. And the chair now recognizes the gentleman from Georgia, Dr. Gingrey. 5 minutes, your question, sir.
Mr. Chairman, thank you very much, and I want to thank all 7 witnesses for bearing with us through the break and the vote series. My question is over a concern that I have in regard to the exchanges and the authority of the Secretary in regard to rulemaking. And I'm going to direct my questioning to the Secretary of the Department of Health Services in Wisconsin, Mr. Dennis Smith, and hopefully we'll be able to get all this done within 5 minutes. The recently released request for information regarding healthcare quality for exchanges on November the 27th specifically mentions a section 1311 of PPACA, which directs quality health plan issuers to, among other things, implement quality improvement strategies as directed by the Secretary. Specifically, subsection H of 1311 would allow the Secretary to prevent physicians from treating patients in the exchange unless they implement such mechanisms to improve healthcare quality the Secretary may by regulation require. Let me restate that. Physicians must follow quality directives as defined by the Secretary or lose their business. Mr. Smith, are you aware of this provision in the law?
I'm not familiar with that section, no, sir.
Okay, well, let me ask you this then. In this provision, you may not know this either, but the word quality is not defined in the statute. So it's safe to assume that the Secretary, not just Secretary Sebelius, but every Secretary to follow, Republican or Democratic administration, will be able to define through regulation what that word quality means. Yes or no?
I believe that is the correct interpretation. I think quality, again, we have tried to introduce quality performances into a variety of parts of our programs, both in managed care, both in the fee-for-service world. Again, this is another one of our concerns that we're going to have state standards, then we're going to have federal standards.
Well, it's a huge concern of mine as a physician member, and I know very well what quality means in regard to the specialty of obstetrics and gynecology as defined by the American College. The same thing for the American College of Surgeons. The specialty societies define quality. If the Secretary decided to use this provision in the law under 1311H, and it's there very clearly, and she or any Secretary uses provision to determine, let's say for an example, mammographies for women under 50 did not improve their health care because of false positives, like her U.S. Preventative Services Task Force did back in 2009. You all remember that. Would a physician be able to treat patients in the exchange if they prescribed a mammogram for a 49-year-old woman? Well, can you answer that for me?
I don't think I can.
Well, I can answer it for you. The answer is no. If the Secretary decided that physicians who performed abortions were not practicing quality medicine because they endangered the life of a child, could the Secretary run providers who performed abortions out of business? And I'll answer that one for you, too. The answer is yes. Mr. Chairman, I believe that this language in 1311 would allow the Secretary to control what physicians prescribe, what health care patients can access. Is there a single person in this room who thinks that the Secretary should have that kind of authority, whether it's a Republican or a Democrat? Mr. Chairman, I have a bill, 6320, which repeals this clearly dangerous provision. And I plan to reintroduce this bill in the 113th Congress. And I hope that this committee, in a bipartisan fashion, can work together in this effort. Because, look, I don't know whether this section 1311, subsection H, was an intentional provision or unintended consequences. I would rather like to think, unintended consequences. But this is the thing you get in a 2,700-page bill that you have to pass and then finally find out what's in it. And maybe you'll like it, maybe you won't. But this clearly is a provision where any Secretary of Health and Human Services can pretty much determine what the quality of care is for physician providers in one of these exchanges in the 50 states and the territories in the District of Columbia, and any specialty, when each specialty society has clearly defined what is quality care. But yet the Secretary now can just say, well, you know, you're not providing quality care as determined by me under Section 1311, and therefore you're basically out of business. You can't be part of a provider panel in the exchanges. This is clearly wrong and has to be repealed. And Mr. Chairman, I've probably gone a little beyond, but I'll yield back now and just remind my colleagues, H.R. 6320 just repeals that section, and hopefully in a bipartisan way we can get that done in the 113. And I yield back.
The gentleman yields back. The chair now recognizes the gentlelady from Wisconsin. Ms. Baldwin, 5 minutes for your questions, please.
Thank you, Mr. Chairman. I am very proud of the work we did in this committee to pass the Affordable Care Act, because access to affordable health care is an essential pillar of middle-class economic security. Many states are making very impressive progress in moving health care reform forward. We've heard Maryland and Arkansas as two great examples of two states that have, it seems, put politics aside and are doing the very hard work involved in implementation because they know it's the right thing to do for the families and small businesses and others in their states. While these states have moved forward, and certainly others have across the nation, I have really been concerned about my home state of Wisconsin and the way it's been holding back. Earlier, Wisconsin returned an early innovator federal grant that would have enabled our state to build a Wisconsin-run health insurance exchange. Building a state-based exchange, in my opinion, would have provided families and businesses with more choices for the quality coverage that our state has been known for providing to our citizens for years. I'm committed to bringing people together and working collaboratively to make our nation's new health law work for my home state of Wisconsin and other states. Our state has a strong tradition and history. Secretary Smith, you talked about that history and tradition of being a national leader in advancing health care reforms. And it is my hope that we can continue in that proud tradition by extending our Medicaid eligibility so that those who need health coverage the most have access to it. Secretary Smith, you mentioned in your testimony, and I read Governor Walker's comments, I believe yesterday, that he has not made a decision as of this moment of whether our state will participate in the Medicaid expansion. Is that correct?
That's correct.
I want to delve a little bit deeper in terms of a timeline in mind for making that final decision. I know you held some press availability yesterday in the state of Wisconsin in anticipation of this visit to Washington, D.C. You made some comments that concern me about this impending decisions. You said the math is just not going to work out, and yet the state has not yet completed its financial projections. There were comments you made about still continuing to build the modeling, and yet you say it's a straightforward calculation. Based on those quotes, what is the timeline that you contemplate for doing that math and having the decision move forward with the administration?
Thank you so much. And again, if I can clarify, my comments about the math were a very specific part of that in terms of whether or not the federal government would buy out our existing childless adults population. So again, my comment was we have about 21,700 childless adults. Even if we get 100% FMAP for them, that is not going to entirely offset the cost of all the new people who would come in to the program. That's what my comments were in
So in terms of just a timeline for the overall calculations that you need to do, how soon can we expect to hear?
The governor's budget. He will include in the governor's budget whether whether or not to expand.
Okay, that's so when the governor's budget is released, we'll know about, that's when he'll announce his decision. Okay, thank you. Well, I just want to repeat that I believe it's crucially important that our state expand the coverage. According to the Kaiser Commission on Medicaid and the uninsured, over 200,000 Wisconsinites could gain Medicaid coverage through the Affordable Care Act Medicaid expansion. And if it is uncertainty that we are concerned about, surely those 200,000 people in Wisconsin deserve the certainty of knowing that quality and affordable care will be there for them. You know, we know the impacts for those 200,000 people, accessing preventative care that can forestall more expensive and costly and sometimes deadly illnesses, and 200,000 people who we hope would be living healthier and more productive lives, or better able to manage chronic illnesses that they might experience. With 100% federal funding for the new Medicaid population through 2016, then phasing down to 90% funding after that point, our state could actually save $250 million in Medicaid costs and another $250 million in uncompensated care costs, factors that we heard testimony from the Secretaries of Health in other states. And on that topic, although I see I'm running out of my time, I was going to ask Director Allison to talk about a little bit more some of the other savings that you've realized that your state, Arkansas, can recognize. Given that I've run out of time, we'll follow up in writing afterwards. Thank you.
Chair, thanks. The gentlelady would recognize the lady from Illinois, Ms. Schakowsky. 5 minutes for your questions, please.
Thank you, Mr. Chairman. First, I want to thank Director Mann for working with Cook County, Illinois, my county, on the waiver that will allow Cook County to early enroll more than 115,000 individuals who will be eligible for Medicaid in 2014. You've given us the opportunity to get a head start on providing the many people who need the health care, who are eligible for the care, to be enrolled. So thank you very much. I wanted to set the record straight on a couple of things, too. There was some talk about the expenses for Illinois that were made earlier. The federal government's going to provide almost $157 million to Illinois to support insurance coverage for 898,000 Illinoisans with Medicaid, reducing our uninsured population by about half. How fantastic is that? And Illinois will save $953 million in uncompensated expenditures. And actually, there will be some increase in the cost for Illinois, about 1%. And look what we're getting. I mean, it's just a miracle to me. I also wanted to point out that in terms of the overall increase in insurance costs, that actually, yes, costs for insurance have increased less than before the Affordable Care Act was passed. And the ACA saved an estimated $2.1 billion on health insurance premiums through the medical loss ratio and rate review. Almost 13 million consumers received a check because their insurance companies spent too much money, over $1 billion, and rate reviews saved consumers about $1 billion. That's individual and small group markets. So these are victories, I think, for. I wanted a number of people have talked about on the panel the problem that somehow the Affordable Care Act messes up your opportunity to get rid of fraud and eligibility requirements, et cetera. And I wanted to talk for a minute about Pennsylvania. My understanding is that in the late summer, the Pennsylvania Department of Welfare began notifying hundreds of thousands of families by mail that they had 10 days to provide necessary documentation in order to keep their children enrolled in Medicaid. And if the family missed the deadline, or even if they met the deadline, but the Department of Public Welfare failed to process the paperwork within 10 days, they were dropped from Medicaid. And in fact, 89,000 children were dropped from Medicaid. Here's my point. Are some of these so-called problems an excuse and setting and the opportunity to set up barriers to actually bump people from the rolls. I think it's completely unfair, and Mr. Alexander, you certainly do have an opportunity to answer, to say that not only do you only have 10 days to keep your children on Medicaid, but if we can't process your papers, then we're going to bump you off of Medicaid, and that happened to 89,000 children. That's concluded in your fraud prevention numbers, and I think that it's a fraud to do that to children. So what do you think?
Well, thank you very much for your comments. When we arrived, Governor Corbett arrived, and I arrived at the department, we had hundreds of thousands of cases that had not been processed in years and left piling up in county assistance offices. And it's our duty as a state, we're mandated by federal law, to follow the laws that you pass.
10 days.
And indeed, we do that. We went through meticulously to make sure that whichever family was eligible, and whichever family was not eligible. Now, this was not about children because we determined this as a family. So we're talking about families and individuals, not just children.
My understanding that the records show that the 89,000 figure represents only children that were dropped
There were
from
much
Medicaid.
more than 89,000. Now let's get to what we did do. We meticulously went through after these, we sent them notices per federal law. We followed the law and followed the
10
regulation.
days is 10 days.
It was more than 10 days. We followed the regulation. We followed the law. We sent them notices. If they did not reply, then they were terminated. So if they did not reply within the accounted time, then they were we gave them every chance possible to
And
come
what
back.
if you couldn't promise? What
And
if you
even
couldn't-
after that, we had done outreach.
And what if you couldn't process? My understanding is, but if the Department of Public Welfare failed to process the paperwork within 10 days, they were dropped.
That's incorrect. By law, it's a 30-day time period. So we gave them ample time, and in fact, it was extended past the 30 days for them to be able to contact us. And we told all of the families that if you come in and contact us and come in and have your paperwork, we will get you right back on the program. The point of the matter is, Congresswoman, is that when you come into a department like this and you have hundreds of thousands of cases that are piled up and hadn't been gone through in years, there's a problem. We have a process that's given to us by Congress. We follow those laws. We have state rules and regulations that we need to follow. Now, if somebody tells us not to follow rules and regulations and they pass laws to that effect, then we will do that accordingly. But we followed all of the rules and regulations. We've reached out to the families. We want everyone that's eligible for Medicaid to be on Medicaid. But if you're not eligible, then we don't want you on the program. There's a difference. We're here to serve the truly needy, eligible families and children.
The gentleman's time has expired. The chair recognizes the gentleman from New
Can
York.
I just say, with due respect, I have different numbers, and I'd like to submit them for the record.
Chair would entertain a glance at those records. Recognize Mr. Ingles for 5 minutes for questions, please.
Thank you. Thank you very much, Mr. Chairman. I want to talk about two issues. I'm going to try to do it fast because I want to get it all in. Involving dish payments and the do-gooder states. I made sure when we were crafting the Affordable Care Act that my state, New York, which is a so-called do-gooder state, was not penalized for it, and also DISH, because we have a lot of indigent people in the New York City metropolitan area. I wanted to make sure that we were not penalized. So the New York Medicaid program already covers most categories of individuals beyond the Affordable Care Act expansion threshold and plans to extend additional coverage to non-pregnant childless adults, thereby fully meeting the ACA parameters by 2014. However, it's projected that after the ACA is fully implemented in New York, 10% of our residents will still remain uninsured, which means DISH funding will still be important. Ms. Mann, I know you and I spoke about the importance of DISH funding. to New York a few months ago. I just want to reiterate how important this funding is to those states which already have broad eligibility for their Medicaid programs or do plan to expand their Medicaid programs. I hope the upcoming regulations will not punish these states who did the right thing by expanding Medicaid eligibility with disproportionately deep dish cuts. I don't know that you have to answer, but as you know, that's a very big concern of mine. Let me ask Dr. Allison and Dr. Sharfstein, can you briefly talk about how declining funding for uncompensated care and DISH influenced your decision to push for Medicaid expansion in your states?
Sure. Maryland, just to give one very specific example from Maryland, because we have a unique way of funding uncompensated care. About $1 billion a year in uncompensated care goes into a pool on the hospital side, and there's about a 7% assessment that goes on every single person's hospital bill in the state for every service to pay for that uncompensated care. So when that goes down, because more people get covered, everybody benefits. Small businesses, individuals, the state, through the Medicaid program. And so it is one of the factors that we use to see, and in Maryland it's very explicit because of this system, you can really see the specific savings and that'll accrue across the state. It's sort of eliminating a hidden tax.
Okay, Dr. Allison?
Congressman, we estimate so far we have found about $90 million per year that the state spends on non-Medicaid programs for uncompensated care. The legislature, the governor will have to make decisions about how to use that funding going forward. We have assumed in our estimates that at least half of that would be diverted to the state general fund, really as an offset to the Medicaid expansion, which is not very different, by the way, from the Urban Institute's assumptions.
Thank you. Let me talk about the do-gooder state issue. As I mentioned before, New York's worked hard to ensure that low-income and vulnerable New Yorkers have access to health care services by expanding eligibility for Medicaid beyond the federal requirements, even prior to the expansion included in the Affordable Care Act. Though the federal support for newly eligible populations is incredibly generous and the law includes provisions to benefit these do-gooder states, the reality is that New York will not see the same federal support as states which have historically been less generous with their eligibility thresholds. So regardless of that, I'm proud of the fact that New York intends to further expand its Medicaid program to meet the ACA threshold of 138% of the federal poverty level. And it's estimated that the state of New York will save $2.3 billion a year as a result of this enhanced federal Medicaid support, with the federal government providing 100% of the funding for newly eligible populations for the first 3 years and providing at least 90% of the funding beyond. I simply cannot understand why a state would choose not to provide health care coverage to its neediest citizens. So let me quickly ask both Dr. Sharfstein and Dr. Allison. Dr. Sharfstein, in your written testimony, you stated, and I quote, "Expanding Medicaid is the best decision for Maryland's providers, the state economy, and the uninsured," unquote. Can you elaborate on the input you received from healthcare stakeholders regarding the Medicaid expansion?
Sure. After the Affordable Care Act was passed, there was a process that involved hundreds of Marylanders, many of whom have submitted comments, business community, the provider community, advocates, uninsured individuals, and there was a real consensus across the state that it made sense to expand coverage, that it not only has been proven to reduce mortality and improve health outcomes, but it would have great benefits to Maryland's healthcare system and economy. And so Maryland has moved forward from that point based on input that we received from across the state.
Dr. Allison, same question to you. What input did you receive from healthcare stakeholders regarding a possible Medicaid expansion in Arkansas?
Virtually all of the healthcare stakeholder associations in Arkansas have come out in favor of the Medicaid expansion. They understand the good that it would do for their patients. They understand the harm that it would do to them as the safety net if Medicaid were not expanded.
Thank you. And Ms. Mann, did you want to make a comment on what I mentioned before? About states do not get punished if they expanded their Medicaid eligibility. Am I done, Mr. Chairman?
Yeah, we've got other members who've been waiting a long time, Mr. Elliott.
Okay.
The gentleman's time has expired. At this point, the chair would like to recognize the gentleman from Utah, Mr. Matheson. 5 minutes for your questions, please.
Well, thank you, Mr. Chairman. Appreciate you holding this hearing. With tomorrow being the deadline for states to declare their intentions with regard to the Affordable Care Act exchanges, I'd like to focus my time on some outstanding questions that remain with regards to the function of the exchanges. There are other issues about the law I'd like to address, such as how the health insurance tax will be assessed and what effect will ultimately have on consumers, but my time is limited, as is the jurisdiction of our committee. Now, the Affordable Care Act envisions a seamless process for consumers to access health insurance coverage through the exchanges or expanded Medicaid or CHIP coverage depending on eligibility. One of the potential unknowns in this process is the issue of how to provide for uninterrupted coverage for those whose eligibility changes during the course of the year due to fluctuations in income. The statute's not clear as to whether these consumers would be able to maintain their existing coverage or if they'll be required to move between private coverage and Medicaid as their income shifts through the year. This potential for churning could not only place significant administrative burdens on consumers and on plans, but could also threaten continuity of care as consumers move between plans with different provider networks. In the end, this can lead to adverse health outcomes for the beneficiary. So I guess I'd direct a question, maybe Ms. Mann would be the one to ask this. Can you provide some clarity on this issue about how these individuals will be assessed and how best the system can maintain continuity of coverage for people who may fall into this situation?
Absolutely. It's a very important question. The Affordable Care Act and the regulations ensure that there will be continuity of eligibility if income changes. So the rules in the law are pretty explicit about ways in which there should be no gap in coverage if somebody's eligibility changes from Medicaid to the exchange or from the exchange to Medicaid. But there is the issue of continuity of plan and provider. And in our recent questions and answers that we released on December 10th, we gave three options for states to consider to try and minimize this disruption of care. Obviously, one of the first things the states can do if they're running a state-based exchange is they can have the same, encouraged to have the same plans doing business on the exchange as they are doing business in the Medicaid and the CHIP program.
Right.
And then families have an ability, even if their eligibility changes, to stay in the same plan. Beyond that, we've noted some premium assistance options that states can use. It's inside their state options in the Medicaid program. They can essentially, as a way of assuring continuity of coverage, they can purchase the coverage for a Medicaid or CHIP eligible person by contracting with a qualified health provider that happens to be doing business on the exchange. That way, if that individual's eligibility changes from Medicaid and CHIP to eligibility on the exchange for premium tax credit, they would switch to a tax credit from Medicaid, but they wouldn't have to switch plans.
All right. Thank you. One other question I want to mention. My home state of Utah is one of several states deciding on which health exchange approach is most appropriate for our residents. And our governor's raised some very relevant questions recently with regard to how the different approaches may operate, some of which I would like to explore if I could. If several states band together to form a multi-state exchange, what role would state regulators play in enforcing state law? We thought about that?
State regulators will have the same role that they do today in terms of reviewing policy forms, making sure they're consistent with any state law, state mandates, for example, as well as with the federal law. So there shouldn't be a change in the role of state regulators in a multi-state exchange.
Is that also the same if they're under the federal exchange, whether it's multi-state, same thing?
Yes.
Do state policy makers relinquish any ability to provide counsel, advice, or influence on the operation of a federal exchange should the state opt out of operating their own state-based exchange?
I think that we are always interested and will continue to be interested in working with states to make the exchanges work best for their state, whether it's a federally facilitated exchange or not. I think that there are some important decisions that states get to make themselves if they are in a state exchange or a state partnership exchange. For example, one example is just how the thing will be funded. We've proposed one funding mechanism which will work in the federal exchange, but states could use a different funding mechanism if it's a state exchange.
Okay. Thank you, Mr. Chairman. I'll yield back.
Gentleman yields back. Chair recognizes the gentleman from from Virginia, Mr. Griffith, for 5 minutes for your question, sir.
Thank you, Mr. Chairman, and appreciate all of you all being here. And I know it's been a long day, and I look forward to working with each of you and the members of this committee as we move forward. Mr. Chairman, I will yield my time to you for questions that I believe you may have.
I thank the gentleman for yielding. Mr. Smith, and again, to everyone on the panel, thank you for your indulgence today. I believe it is the policy of this committee. We invite smart people to come and tell us what they think about things. If there's an opinion that needs to be offered, I think it should be offered. So, Mr. Smith, a long time ago, Mr. Waxman offered some comments to which you wanted to respond. I know we've kind of removed the immediacy of your response to those comments, but if you had comments you'd like to make, we'd love to hear them now.
Thank you, Mr. Chairman. I appreciate that greatly, and it is nice to be with a bunch of smart people. So, the question about block grants and what I want to respond in a couple of different ways. First, State Children's Health Insurance Program is a block grant. That was one of the most successful programs that everyone has claimed great credit for. There are different forms of block grants. There was a per capita cap approach that during the Clinton administration, Clinton mission officials supported that type of approach. The block grants themselves, again, for states, we do believe we can run these programs more efficiently and more effectively than the federal than under federal rules. So, first of all, more than half of Medicaid dollars are spent because states have expanded beyond federal requirements. We've added eligibility, we've added benefits, well beyond what the federal law expands. So again, the sort of the perspective that if the federal government doesn't require it, the states aren't going to do it. The history is actually the opposite. States have expanded beyond what the federal requirements are, so we believe very strongly states can indeed be trusted. The great deal, most of the money is in people who are either senior citizens needing long-term care or individuals with disabilities. In Wisconsin, we have, in fact, lowered the cost of care because we have been able, through waivers, put people into private sector managed care situations. Again, regular Medicaid fee-for-service is the most expensive type of care and in many respects least appropriate because the care is not being provided for. So from my perspective, when I look at all of these Medicaid dollars that are being spent under the different formulas that have been offered, which guarantee federal dollars growing by population, at least medical CPI or CPI +1, I say absolutely, I can make that deal work. If my federal dollars are guaranteed, I become more efficient. The state, therefore, actually increases the federal match rate because the state match goes down because the federal dollars are guaranteed are going to be there. So absolutely, we can make that situation work. There are, again, I go back to the very beginning before legislation was even put out. In December of 2008, Chairman Baucus at the Finance Committee put out a paper saying there's $700 billion in excess spending in the healthcare system. Through Medicare and Medicaid, government spends almost half of those dollars. Medicare and Medicaid, therefore, do indeed have to be brought to the table, and there is a great deal of overutilization in the system. From our perspective, again, it's not the cost of health care, it's the excess cost of health care. The excess cost of health care is what we're going after. We've done it successfully in Wisconsin. We think we can go even further.
Well, and along that line, I'm just terribly disappointed to hear Mr. Cohen's response to the medical loss ratio question in health savings accounts. You know, Mr. Pallone, I sat on this committee with you down at the kids' table while we heard all the comments about how to bring down cost of health care. That's what the Affordable Care Act was supposed to do. Remember, the word affordable was in the title. If we wanted to bring the cost of health care down, we would have invited Governor Mitch Daniels to this committee and asked him how he did that in his state, 11% reduction over 2 years. He did it with a health savings account for his state employees. It was voluntary, but he found out something important. that people, when they spend their own money for health care, something magic happens, even if it wasn't their own money in the first place. It sounds like, from your interpretation of the medical loss ratio, that effect is going to be lost. That is yet one more failing of this very large law that came into being in a under very difficult circumstances. I'll yield back my time and recognize Dr. Christensen, 5 minutes for questions.
Thank you, Mr. Chairman. And thank you to all the witnesses for your patience in being here with us today. I, too, am very proud of the work that we in this committee did on the Affordable Care Act, and I don't want to see any of the gains lost. I want to see every one of the over 30 million people who are going to receive coverage, including the 20 or so million who will receive coverage through Medicaid expansion. And a large percentage of those are people of color, for whom the Tri-Caucus worked very hard during the as we put together this bill, this law, to ensure that African Americans, Hispanics, Native Americans, and Asian Americans had access to health care. And I wanted to go to one of our poorer states that is not about to accept the Medicaid expansion, I don't think, or maybe no Medicaid expansion, no state exchange. Mr. Greenstein, you mentioned in your testimony that Louisiana has some of the worst health statistics, and your state has some of the most persistent health disparities in the nation. Numerous studies have shown that expanding access to health care through programs like Medicaid help to reduce health disparities. The National Urban League released a report last week about the economic cost of health disparities and found that the health disparities cost this nation more than $82 billion in direct health care spending in just 1 year. And the highest burden, of course, is in the South, where health disparities cost about $35 billion in just 1 year. So aren't you concerned that not expanding Medicaid would exacerbate the disparities in your state, leaving more people as the sickest in our nation, and also increase the financial costs in the end, because they're going to come to you at some point without having preventive care, without having health care maintenance, when they're very sick and cost the state more?
Thank you very, very much to focus the attention on what all the coverage is supposed to address, which is people's health status and the health outcomes. Indeed, in my state and many other states nearby, we see great disparities in diabetes, in obesity, and they're dramatic. We have looked at the outcomes for people on Medicaid and those without insurance, and we don't see a great deal of difference. This is distressing. We have a system that's not churning out the kind of health outcomes that we would expect for the amount of money that we put in. We've looked very deeply at expanding Medicaid, and let me share with you some of the numbers around it. I believe Chairman Waxman went through the numbers in Louisiana that we would expand Medicaid, how many people that don't have insurance would get it. And he cited about 265,000. When we looked at our numbers, in the first year alone, 467,000 people would join the Medicaid rolls. Of that, 187,000 people already have private health insurance today. We would see a cannibalization of the private health insurance market, taking generally healthy risk from a system where people pay some portion of their care and move that into Medicaid. Hospitals, doctors would see reimbursement levels reduced. So this is not an easy way to think through that expansion equals better health outcomes for everyone. It doesn't.
But nothing, as I understand it, precludes you from making changes within the Medicaid system to address some of the areas that, you know, may not be working, so that where you now see that Medicaid-covered patients don't do any better than patients who are insured. So, Ms. Mann, is there anything that I've heard several of the panelists say that, you know, the law dictates to the states, does not allow them the flexibility. Is that the case, or can't they also fix whatever is wrong with their Medicaid system under?
They can, and we would hope that they do, and we'll be prepared to work closely with Louisiana to do just that. There's a study in Oregon that recently came out that looked at people on Medicaid and people not on Medicaid, had a control group. It's considered a gold standard study. It showed definitively that the care and the well-being and the health outcomes for the people receiving the Medicaid coverage were far superior to those who weren't having health care coverage and who were uninsured. There's lots of issues in Louisiana that are difficult, are challenging for anyone to tackle. But the evidence around the country is that you can make Medicaid work well for beneficiaries and improve health outcomes. The discretion around designing the program, determining the delivery system, contracting with the providers, those are all decisions that are fundamentally state decisions in the Medicaid program.
But may I offer an idea on eligibility? You mentioned Native Americans as a specific population. When we are switched to modified adjusted gross income, in Medicaid currently, where Native Americans are exempt from cost sharing entirely in the Medicaid program, in Wisconsin, we disregard certain income that is available to them as members of a tribe. That gets changed under MAGI. Those people will become tax credit eligible, where they will be paying cost sharing rather than Medicaid eligible.
I don't think that's the case.
That's
I know my
not.
time is up, and I hope that Ms. Mann and Mr. Cohen will have a chance to respond to that, because I don't think that's the case.
Gentlelady's time has expired. Recognized as a member of the full committee, Mr. Sarbanes. 5 minutes for your questions, please.
Thank you, Mr. Chairman. Thank you for letting me participate today in the hearing. I appreciate it very much. I just want to say to Mr. Cohen and Ms. Mann, thank you for your tremendous work on this. It's incredibly exciting, actually, what you're doing, because you're helping to build an expanded infrastructure that's going to provide more access to millions of Americans, and over time, I think, also begin to rein in healthcare costs in a very effective way for individuals and for the system as a whole. I wanted to ask you, Ms. Mann, real quickly, what do you anticipate when we get to the end of this process in terms of the number of states that will actually have done a state-based exchange versus those that will have done a partnership exchange versus those that will be federally facilitated? Any kind of sense of where that is? That
I think that's actually for me. We don't know yet.
Yeah.
There is a deadline on the state-based exchange that's coming up this Friday. So far, we've heard from 14 states in the District of Columbia have said they want to be state-based exchanges. There may be more by Friday, but we don't know that. The second deadline that comes along is February 15th of next year, which is when we've asked states to tell us that they want to be in a partnership exchange. So we'll know more in February as far as how many want to work with us.
Okay. All right. Well, let me ask you, Dr. Sharfstein. First of all, thanks for being here. Congratulations on the work in Maryland. I know you and Governor O'Malley and others that are a part of this effort have really been a part of the vanguard in demonstrating that these state-based exchanges can work and can get in place. And we're very proud of that in Maryland. I wanted to ask you, in view of the fact that states soon will be making a judgment about whether they think they can stand up a state-based exchange, and in other instances we'll be looking at the partnership model. You talk to your colleagues around the country who are making these decisions. What are the kinds of anxieties they express to you that you're able, based on Maryland's experience, to say, look, there is a way to do this? And whether it's certain technical things that you would comment on, or just the process of sort of how you get consensus behind it and get people comfortable moving forward. What are you saying to your colleagues who maybe want to get there but are worried a little bit about it, based on the Maryland experience, that can give them some comfort and confidence that they can do this?
Sure. Thanks for your question, and thanks for your leadership in Maryland. We really appreciate it. There's a lot of engagement with the states that are moving forward on the state-based exchanges. There are a number of calls that happen. There are exchange of documents. Sometimes it's very explicit, like a document or analysis that we'll do, other states will use directly, or we'll use something that they've done. And sometimes it's more just talking over, different situations. A couple days ago, up in West Baltimore, we had a meeting of the Exchange Board, probably 75 people in the public watching. We worked our way through a bunch of issues that we've been talking to our peers around the country, how billing would be done. We resolved that the exchange would take the first payment, but the carriers would do the payments after that. And that's an issue where there's different ways to go. We have figured out a way to partner effectively with insurance brokers, and we adopted some policies related to that. We decided to offer adult dental and vision plans if possible in the exchange. So for each of these things, there's a discussion. And I understand there are a lot of details involved, but we've gotten energy from talking to people about those details, both within our state and with other states, and systematically, step by step, moving forward with each part.
I just want to emphasize that from the beginning of this process, obviously a state looking at it without any peers having undertaken the process, without CMS and others having fully gotten into it yet, you could look at it and it would appear very daunting. And states like Maryland decided, we want to get out in front of this thing, and other states did as well. But we're now at a point, as a result of this, where the expertise that resides in CMS, practical expertise about how implementation of this can happen, plus the expertise that resides in a peer group of states that have started to build these exchanges, have created the models, have looked at the computer systems and how all that's going to work. It means that states that maybe didn't get started as fast as they could are now, if they make the judgment to go forward, are going to come to the table with a, let's call it a support group or a network of people that have hammered through a lot of these issues, and they'll be able to get where they need to go maybe faster than you had to do it, starting from scratch. But that's important, I think, in making people understand that this is very feasible. And if people get into this and start working on it, we're going to get this framework in place. Thank you very much.
Gentlemen's time's expired. That concludes the questions from the members of the subcommittee and members of the full committee who wish to ask questions. We have time, I think, for 2 follow-up questions, one from each side. The chair will recognize Dr. Cassidy for our side. 5 minutes.
First, let's just give some reality to some of the quotes regarding Medicaid expansion improving health care. That Oregon study you quote, Ms. Mann, was a study limited to Oregon on an outpatient basis, and there is some evidence that people felt better just because they won the lottery. Secondly, as regards the New England Journal of Medicine article you quote, Dr. Sharfstein, it was driven by New York solely, and in fact in Maine, although it was not statistically significant, the Medicaid expansion resulted in poorer outcomes among those who were on the Medicaid. Now, it was not statistically significant, but that was entirely driven by the state of New York. And as regards Mr. Ingalls, speaking of the do-gooder states, I'll point out that New York pays physicians less well than does Louisiana and Texas, and only 60% of physicians in New York accept Medicaid. That is not access. Now, that said, just to clear up the record a little bit, let's go to, oh heck, dadgummit, I lost my questions. Here we go. Now that we know, Mr. Smith, that the one thing that has been shown to lower costs, which is health savings accounts, will not be allowed in the MLR unless it's actually spent, i.e. we're no longer lowering costs, we're now encouraging insurance companies either not to sell them or perhaps the insurance company to encourage the person to sell it. What data do you have in your state on the effect of the increased premium cost on someone who's, say, 200% of federal poverty level, who's currently employed with employee-sponsored insurance, dumped into the exchange, as McKinsey Quarterly says about 30% of these employers will do, now has an actuarial value of 60%. What do you project is going to happen to that person?
Thank you, Mr. Cassidy. Again, we have been modeling the PPACA premiums in Wisconsin Medicaid since the 1st of July.
So you actually are seeing, this is not a computer model, you are actually got real life data.
Yes, sir.
Okay.
This is the actual experience. Wisconsin has already expanded Medicaid coverage. We have parents, caretaker, relatives up to 200% of poverty. Some of our eligibility groups of transitional medical assistance, individuals with income above 300% of poverty. We have started applying only the premiums, not any of the additional cost sharing.
Not the $2,000 deductible?
No, sir. This is only premiums, not any additional cost sharing that would be in effect. So in the results to date, people at the lower income level, again, because they're looking at a dollar amount. They're not thinking of a percentage.
Yeah,
of
Washington,
poverty.
we speak about percentages, huh? But we're actually talking about a dollar amount.
Yes, sir. So at 133 to 150% of poverty, and again, because the poverty level includes not only someone's income, but also the size of the family, and so you're a percentage of your gross income. So
Please hurry, I have one more
I
question.
apologize. For people paying over 200% poverty, the average now of $200 a premium, participation was cut in half. So people are saying, we're not paying $200.
So 50% more people are without insurance?
50% of people who had been enrolled dropped their Medicaid coverage when premiums.
So when that working family's employer puts them on the exchange and they have an actuarial value of 80% with the employer, but it may be 60% on the bronze level, they're facing premiums and deductibles they've no longer faced before, they are dropping their coverage potentially?
Exactly, because you have, again, the employer.
This is good for the American worker?
I think the results are going to be quite different.
And this is not theoretical, this is your actual experience, correct?
Yes, sir.
Oh, now, Mr. Greenstein, we speak of percentages in D.C., isn't it interesting? And that Kaiser Family Foundation, based on the Urban League, speaks about how much Louisiana is going to get. But actually, it's going to cost our state, according to that study, $1.8 billion over 10 years, please.
We suspect that those figures actually are understated and don't capture the full administrative costs.
And they also, I might say, probably understate the amount of taxes that will have to be raised for those costs. A macro effect that it's ignored. Continue.
Likely. When we looked at the study, we recognized that there were very large shifts in winners and losers. Some states end up reducing their overall burden, some states increase. But when we talk, and a good part of the discussion today has been about how states are going to save so much money by Medicaid expansion, it's just shifting costs from one place to another. At the same time, this is all net new spending.
I agree with that. So one more question for Ms. Mann or Mr. Cohen.
We'd better cut it off.
Oh, my gosh.
You can submit it in writing. You have till December 27th, sir.
Thank you all.
Recognize the ranking member of the subcommittee. 5 minutes to your question, please.
Thank you, Mr. Chairman. Ms. Mann, I just wanted to give you an opportunity to respond to the comments made by Mr. Smith, if you would.
On the issue of the block grant, I think, is where I was
Whatever you
trying
like.
to jump in. Yes. A couple things to say. Thank you for the opportunity. One, Mr. Smith harkened back to noting that the Children's Health Insurance Program is essentially a capped allotment. It functions as a block grant. That is true, and what we need to recall, although it's hard to remember back that far, is that in the early years of the CHIP program, states ran out of money. States were desperate because the dollars allotted was what Congress thought they needed, and of course it was a set amount of dollars, and it turned out that the enrollment was higher and the needs were higher, and states were on the verge of shutting down their programs or putting their state dollars on the table to cover children. That is the nature of a block grant. It is a capped amount of money, and it shifts risks onto states and ultimately onto vulnerable Americans who are covered by those programs. Mr. Smith talks about who can do a better job. Can the states do a better job? Can the feds do a better job? It's really not about trust. It's really about having a financial partnership that works. I would submit that without that financial partnership, we would be moving into 2014 with states operating 20-year-old legacy systems if we didn't provide some additional federal funding to help states finance their eligibility. I would submit probably without that flexible financing, we would not have had the situation where over the years people with HIV and AIDS were able to get the care that they needed, expensive care, and then were able to live healthy and productive lives, or poor children with leukemia or with autism were able to get effective care to help them. When you have a capped amount of money where the federal government says, that's all I'm going to do and I'm going to do no more, we risk those kinds of results. What we need and what's good about that partnership, while it's fraught with some tensions, is that it keeps us all at the table to make sure the program is as strong as possible. We all have incentives to get better care and to do that at lower costs, and that partnership helps us get there.
Right, thanks. Then I just wanted to give Dr. Sharfstein and Mr. Allison an opportunity to talk briefly in closing. Why is Medicaid expansion the right answer for your states? And if you had to convince the 3 other states here, what would you say to them about it? You've got about a minute and 10 seconds each.
I would ask them to spend some time with individuals who would get coverage and who need coverage or who benefit from Medicaid coverage. I think we all agree that there needs to be more value in health care. I think we all agree that we need to get excess cost out. But I think basic services and basic health care for people shouldn't be considered excess. And a couple nights ago, I was at a church in Howard County with about 300 people in the developmentally disabled community. And a mom got up and talked about what Medicaid meant for her daughter born with a heart defect, and it was just a harrowing story. And then the little girl ran across and basically gave me a hug. And it was a moment where we could just stop and say, this is what Medicaid stands for. We want to get Medicaid to work. We need health care to work, but it shouldn't be don't expand, keep people out first. It should be let's get people in and move forward with the health care system.
Okay, thanks. Mr. Allison?
Congressman, thank you for the opportunity. I would just say that, Congress passed and the Supreme Court upheld a law that provides significant incentives to states to save the lives of its own citizens, to improve their health, to provide to them financial protection. I represent a poor state with many who are uninsured and will, without this support, never be able to afford care. We know that care makes a difference. It may be that we face challenges in the future to assure that this remains financially sustainable, the new commitment that we're making, but I would just encourage my fellow states to consider the opportunity which has presented itself now.
Okay, thank you very much. Thank you, Mr. Chairman.
Gentleman yields back his time, all time having expired on the committee. Mr. Pallone, there was a unanimous consent request from your side about providing some data about Pennsylvania, and without objection, I'm going to make that part of the record. But Mr. Alexander, I think in fairness to you, I'm going to submit a question to you about this data, and we'd be very grateful for your reply to that. The same courtesy will be afforded to Ms. Schakowsky as well. And I want to remind all members, I said earlier 5 business days. It's actually 10 business days to submit questions for the record. And we will ask the witnesses to respond to those questions promptly. Members should submit their questions by the close of business on Thursday, December 27th. And by happy occurrence, we will be here on Thursday, the 27th. So without objection, the subcommittee is adjourned.
Where did you hear it?